3, 2, 1. We are live.
Welcome everybody. A very, very warm welcome to our President, Dr. R.C. Meena sir, and a very warm welcome to the entire IOACWC and all our friends and colleagues and to our esteemed faculty today. This is a very, very unique opportunity. Despite the pandemic, we have managed an excellent program and really shows that how human spirit can really be resilient in tough times. And I'm especially delighted because my friend Taral is also with us. So what we thought is, what is very important to bring to the general orthopedic surgeons, something that is practical, something that is technique based, and something that basically essentially is a dialogue between our colleagues who practice a different branch of orthopedics and us who have focused onto a smaller aspect, but a very, very important aspect of orthopedics. So I would now request Dr. R.C. Meena sir to formally inaugurate this mini workshop of the mini IOACON. And I'm sure that is going to have a mega impact on the lives of a lot of children and the orthopedic practice in future, because we have a battery of speakers who are all veterans with what they do, and they will really take you through very, very technique-based tips and tricks and practical modules of some of the list of topics that we have given here. Over to you, sir. R.C. Meena.
Thank you, madam. So nice of you giving me this opportunity and having a so wonderful regard in your subject, especially in your heart for me, at least. So, dear friends, very good evening and good afternoon from the House of Organizing Team of IOACON Jaipur. Actually, initially, I was in very sad mood that how I will organize this conference and how I will draw the faculty and how will I get the support of my super specialty fellows. But when I come across the super fine brain of the country and the different super specialties, among them one Dr. Rajuta is one, and I sincerely thanks to him that she accepted my offer to organize a pre-conference Paediatrics with mini IOACON 2020 a workshop, so that a week of academics for this conference can be started in a very glorious way and in a very attractive and exciting manner. Now that has been proved that since morning multiple phones has been come on my telephone that, sir, when will be available the link to how we will join the Paediatrics workshop and from where we can get this link. Then I told them all that you wait, just wait up to the 1 p.m. you will get definitely it. And the Paediatrics Orthopaedic, in the field of orthopedic, general orthopedic, has a great importance. Every man, every orthopedic surgeon having children, and they knows the importance of this Paediatric orthopedics. How it is important for it, not only the Paediatrics practitioners, orthopedic surgeons, but all the common men, that the importance of this specialty is really, really demandable of today's mind. And thank you very much. Rajuta has accepted my invitation for this workshop. He has drawn so many super fine specialists of the Paediatric orthopedic, Dr. Taral Nagda, from a difficult period has concentrated, has enough to join this workshop. Dr. Molin, Dr. Nayak, Dr. Gangwal, Dr. Sandeep, and many more. Those who are not visible on the screen, maybe out of the screen, but viewing this scene and giving support to this pre-conference workshop of the Paediatrics Mini IOACON 2020. And I am sure this academic feast, this academic extravaganza of this workshop will definitely benefit a common orthopedics practitioner and our young generation who is not much expert in the pediatric surgery. definitely will be benefited by this kind of activities, and hope this kind of activity will Dr. Rajuta continue to give a lesson, a practice, a training to our orthopedic surgeons. Thank you very much, madam. Once again, you and your team, and one and everyone who is watching this video and this live workshop, and I hope you will be benefited definitely. In the last but not least, I request you all to either please join physically at the Jaipur. Jaipur is very safe from corona point of view, but if it is not possible, then join virtually as well. And you all are welcome. You all are the very valued member of IOA and orthopedic fraternity, whether you are the IO member or non-IO member, but you are having a great value for us as an organizer. Thank you very much, madam. Keep.
Pleasure, sir.
Thank you.
My co-conveners, Dr. Sandeep Patwardhan and Kapil Gangwal, will be co-moderating this session with me. So without much ado, let us start with Dr. Taral Nagda, who is actually going to show you exactly how to live the president's theme, which is excellence and perfection in orthopedic education through practical learning. And therefore, he is going to present this in a very, very innovative way. And hats off to Taral for that. So over to you, Taral, our opening batsman.
Absolutely. So I'm going through a lot of inquiries in my life, and this is going to be as a conversation, dialogue between Guru and Sishya, and that's how it's going to be. So I invite Varun, our fellow at Jupiter Hospital in Pediatric Orthopaedics, to ask me queries, and I'm going to answer that. So Varun, please start. Thank you. We cannot hear you, Varun.
Hello, can you hear me?
Yeah.
Yes. So today we'll be going through different scenarios with respect to lateral condyle fractures, and I'd like sir to explain and also explain regarding the decision making and also the treatment procedures in all of these. So this is probably one of the a type of X-ray we might come through in practice, wherein we see undisplaced lateral condyle fractures. So here is a case of 5-year-old who came with a history of trauma. She came with a history of fall while playing. So in this case, what needs to be done, sir? And how would you treat this, and how would you actually diagnose what steps need to be taken after a case such as this?
So quickly, what I want to say is the 5 procedure which we are going to describe today is a conservative management, effective conservative management, fixation in situ, close reduction, arthrogram reduction, and fixation. The 4th procedure is open reduction. So these are the only ways in which you can treat an acute lateral condyle fracture. So if you know how to master these techniques, you have learned how to treat. Now this is a very common thing. The first thing Varun you should do is take proper X-rays. Okay, so take X-ray in internal rotation. So show that this is X-ray in internal rotation, and this X-ray in internal rotation is a must. Just AP and lateral are not enough. Secondly, this X-ray should be taken out of slab. X-rays in slab don't have meaning. Okay, so this fracture is an incomplete fracture. We saw on internal rotation view that it is just a metaphyseal fracture, not going completely into the epiphysis. We classify this as a stable fracture. There is no need to do MRI, arthrogram, no need to admit the child. Just apply a well-fitting slab. Now this slab, something which I want to tell technique-wise, the slab has to be with wrist in extension, because common extensor origin is attached here, and it should be in supination. So that's how you are going to apply slab. Why not plaster? Because we need X-ray at 1 week, so that's why no plaster. Okay, so what I'm going to do is call the patient after 1 week, next one, and then confirm that everything has been good. Again, take AP lateral oblique views, and if everything is good, this is not going to displace further, and then all you do is give a proper plaster, again with wrist in extension, elbow in forearm in supination, and then call the patient at 4 weeks for final X-ray, 3 to 4 weeks. In younger child at 3 weeks, older child at 4 weeks. How long do you give this plaster? Till the time fracture heals. So it's not necessary that you should give plaster for 2 weeks or 3 weeks or 4 weeks or 5 weeks. You have to have radiological evidence of healing in these fractures. Simple fractures, you need to take proper x-rays, take proper decision, and go ahead. Yeah, Varun. So go ahead. If there are any questions, you can ask. Okay, go ahead. Let's skip some of these theory slides. These are words of wisdom. And what we know as almost half of the fractures can displace, which doesn't mean that you have to fix all undisplaced fractures, because by fixing all, you are over treating 60 to 95%. Next one. It is also known that those who shift will shift in first 5 days or in a week's time. So if your X-ray at 1 week shows that the fracture is not displaced, it's not going to displace further. So I just want to take away the myth that every in position lateral condyle fracture has to be fixed in situ. Not required. Almost 50 to 95% of them can be treated conservatively, even without doing an MRI subjecting the child to anesthesia. Go ahead, please. Quick.
But there are fractures which displace. So which are the ones which actually
So
displace?
I'll show you. So I'm going to. So this is a very important question. There are fractures which displace. So on internal rotation view, if the lateral gap is more than the medial gap, if the fracture lines are parallel, then those are the ones will displace. On the lateral, if you see there is a displacement, they will displace. And on 1 week X-ray, if the fracture is displacing, those will displace. Now, necessarily what is happening, the fractures which are going to displace are the ones where fracture has extended to the articular surface. The fracture which are not going to displace are the fractures which have not extended to the articular surface. And X-rays don't show that. But there is no need to do an ultrasound on MRI in every case. If you just follow these simple principles, go ahead of looking at the fracture anatomy, taking proper X-rays, and doing a follow-up X-ray at 1 week, you will be correct almost always.
Thank you, sir.
Go ahead, please. Yeah.
Is there an algorithm which we can follow?
So there is an algorithm. I will. Yeah. So I'm in interest of time, I'm not going to go through this algorithm, but I have already described that you take X-ray in internal rotation. Look at the X-ray. If the fracture is displaced more than 2 millimeter, if it's a divergent X-ray, articular, the fracture line is parallel, or on lateral, if it's displaced, then those are sort of unstable fractures which need to be fixed. If you don't have any of those signs, then you can conserve in plaster at 1 week, take an X-ray. If it's not displaced, then just conservatively treat.
Okay. So here is another child who is a 5-year-old with a history of fall while playing.
So this is a complete fracture, complete undisplaced fracture. On lateral, there is no displacement. Again, what will you do? Take X-ray in internal rotation. And you see here that the medial gap is not very high, but the fracture line is going all the way down. Now this is invertible. So you have to talk to the parents. There is some risk of displacement. And in this patient, I will do an MRI. So what I do is we admit the child, sedate, ideally would do an MRI. And if MRI show that the articular surface is not bothered, then I will give plaster in the MRI department and send back the child. Okay. However, if the articular surface shows that the fracture line has gone through the articular surface, if MRI shows that, then we will shift the child to the OT, pass 2K wires and treat this. So that's my algorithm. So in this child, patients refuse MRI. And what we did is very simple. When patients refuse MRI, call them after a week. It showed good healing. There was no further displacement. So you leave the patient alone and he healed very well. Go ahead.
Yes. So here is another patient who's again a 4-year-old with a similar.
So these are all similar looking fractures, but the algorithm is different. So again, now you can see that the medial gap is quite wide here. And these are the fractures which are unstable. Go ahead, please. Next one. So this is unstable fracture. This patient came with an MRI, but you don't need an MRI in this patient. You don't even need an arthrogram in these patients. What you will do is these patients take under C-arm, under short anesthesia, pass to percutaneous K wires, and then it will be fine. It's important to realize that lateral condyle fracture is not in vertical or horizontal plane. It's an oblique plane. And that's why all your fixations have to be with elbow in internal rotation. Okay, so in this patient, just for demo purposes, we did an arthrogram. It's really not required. If you are confident, you can do it. But what is required is take this patient under anesthesia, reduce the fracture in valgus, take the X-ray in internal rotation and pass 2 wires which will go from anterior to posterior. It's important that the wires are not in mediolateral plane. They go from anterior to posterior. And again, it's important that you follow up these patients in healing. maintain the K wires. For undisplaced lateral condyle fractures, I put wires outside. For displaced one, I put the wires inside. So there was a question by Atul in one of the meetings. How do you decide whether to keep wires in or out? And that's my algorithm. And always follow up till healing. Okay, don't leave the patient till the time it has healed. Go ahead.
Yes.
Let's go a
So
little
another
quick.
with 8-year-old with a similar injury.
Yeah.
So such injuries, would you do an MRI in these cases?
So so this is indeterminate type. Go ahead, please. So this requires fixation. Really, it's not necessary that MRI should always be done. Not available everywhere. Not safe to do MRI in a child. But in that fracture, child came with an MRI. Go ahead. So you can see that the fracture line is going across in AP and lateral, and this patient requires close reduction and pinning. So what you do here, since the articular surface was involved and it was an unstable fracture on stress views, that's one more thing you do intra-op. What you really require here is an arthrogram. So the question again is whether to do arthrogram or fixation first. What I do is I fix them and do arthrogram later on. Once you do the arthrogram, the fixation is very difficult. There are two techniques of doing arthrogram. Either you can go from behind or from the lateral aspect, and these techniques are well described in books. Okay. Go ahead, please.
Yes. So this is
one more patient here.
Arthrogram, close reduction arthrogram.
Showing how to do a lateral approach arthrogram. Show the video, please. So that is something where MRI is not even required. It's a completely unstable fracture. So you need a reduction in these patients. You need to reduce. You need to make sure that in valgus and pronation you reduce this fracture. You use K-wire as a joystick and keep the elbow in internal rotation whenever you're fixing. Now this doesn't require a screw. Very young child, small metaphysis, 2 divergent or 3 divergent K-wires are enough. Okay, so this is showing how to do an arthrogram. So this is how your wires will go first. With your thumb reducing the fracture, the assistant holding the elbow in valgus, giving valgus traction, reducing it, and you use tip of the K-wire to reduce the fracture, to give the pressure. It's very important that when you pass the K-wire, don't rotate first, pierce first, and then rotate. You will pierce through the cartilage and rotate through the bone. Yeah. So the way you pass wires is again very important. So 2 divergent wires here, and then doing arthrogram. Yeah. Varun, go to next slide. I think people. Yeah. So that's the arthrogram after passing the wire. You have 2 divergent wires. Why I've passed 2 wires which are of different diameters? Because it's easy to recognize them in AP and lateral. If you use same size wires, then it becomes very confusing which wire you should advance. Because in lateral condyle, it's a very soft bone, and more you put the wire in and out, they lose the hold. So avoid too many attempts as passing these wires. If you are, again, one more sort of trick is if you have too many attempts, then you create a hematoma, and which gives rise to lateral bump, and which is unsightly, and parents will complain about that. So if you've gone soft, if you've gone gentle, then you will avoid a lateral bump. Yeah. So that's how things have been fixed. Yeah. Go ahead. So sometimes you may need to pass a screw in an older child. So what you do is pass 2 wires. First wire is a K wire, which is on the medial side, the thin wire, guide wire, and then screw. And as you tighten the screw, I generally prefer a fully threaded screw, not a partially threaded screw, because partially threaded screws will crush the cartilage. I use a fully threaded screws, but I reduce the fracture with a thumb pressure. Okay, go ahead. So again, when you pass a screw and a wire, you can remove wires early. So wire is outside, screw is inside, and the screw is removed at 3 months. So that's the advantage of having a dual fixation.
These are the follow-up images.
Yeah, with the presence of screw, you can mobilize at end of a month. You don't have to give 6 weeks or 8 weeks plaster. The screw allows you to mobilize early. So what I do is at 4 weeks, I remove the wire, let the screw be inside, and then mobilize these patients early because these are intra-articular fracture. Ruja, just tell me about the timing. Yeah, go ahead.
Yeah, still fine. Go ahead. We started at 4:10.
So this is with respect to open reduction, and again a 7-year-old with a similar history of trauma.
Yeah, so
This
this
is the
again
X-ray.
tells you what should not be done. So bad X-rays, X-rays through slab, not taking internal rotation view. So all these things were done, and this patient ended up later on with a flipped over uh, lateral condyle fracture. So many people ask me what is the duration for open reduction. So this was just 3-week-old child fracture. So up to 3 months or 6 months, I would do an open reduction if the fracture is flipped over. If the fracture is in position, if the range of movement is good, I fix them in C2. But a fracture like this, which has tilted, flipped over, close reduction will give rise to restriction of movements. So you need to choose your cases well. So this is an indication for open reduction. The main problem with open reduction is the approach, because you don't want to lose the blood supply. So that's a classical lateral approach which you take. So this is video has been taken almost 10 years back, but it still holds good. So you cut skin, subcutaneous tissue, and examination is very important here. You straightway go to the fragment. There'll be a fracture hematoma. You will aspirate that hematoma. And important thing is to go to the fracture site first. So you start more proximally from a normal bone, come down, go to the fracture site. Try avoid handling the fragment. That's my sort of okay. It's important to do capsulotomy. If you don't do capsulotomy, you will not see the elbow joint. And if you don't see the elbow joint, you can't reduce this. What I do to reduce this fracture is, once I have sort of delineated the margins, then I use K-wires as joysticks. You can also use a fork. Atul uses that. I also found it very useful. So a fork to reduce, but most of the time K-wires will do the job. Identify the fracture, and as you can see here, use very gentle techniques to separate the fracture. This has been almost 6-week-old fracture, bound to have some adhesions. You have to be very, very careful, but maintain the posterolateral blood supply, because that's the lifeline of this fragment. So once you have sort of cleared the fracture area on the metaphyseal side, once you have cleared the fracture area gently on the small fragment side, you will be able to reduce this fracture. You are seeing that I'm using an Alice's forceps to hold it. Okay, I'm using my thumb pressure. I'm using suction to also manipulate the fragment. Okay, and you can see that though it's a lateral approach, I can see my anterior joint line very well. It's very important that the retractors are placed in the right place. And now this is a K-wire, which is I'm using as a joystick. Coordination is very important. So it requires two intelligent pediatric orthopedic surgeons to do a lateral condyle case. If it's a non-union, it requires me and Sandeep Patwardhan. Okay. So go ahead if you have a control, and if you can fast forward, Varun, because we need to finish in time.
Yes.
Yeah, so that's multiple K wires now used to fix divergent wires. One wire going parallel to the articular surface, the other wires in different planes. Don't go with a fixed mindset here. You may have to use the best fixation here. Always use screws in delayed cases, because you need to mobilize them early. In this case, which was done many years back, I've used a washer, but nowadays I don't use a washer. It's more difficult to remove the washer than the screw, and it irritates the child's range of movement. So nowadays I don't use a washer. Yeah, go ahead, please.
Yes.
Yeah, show the post-op X-ray. Post-op
This
X-ray.
is
Yeah, these
this
are
is a
some of the images intra-op, post-op X-ray. A wire and a screw. Again, screw going from and obliquely, across the fracture site. Yeah, go ahead.
this is
So
a
remove
third.
wires early, mobilize, remove screws late. That's the principle.
This is 4 months.
I
And
think
this is
yeah. So these are the techniques which I've shown. I think we can end here. There is also a video of the posterolateral approach, but I think we'll skip that. Just stop sharing your presentation.
okay.
Already 16:29, so I think we should finish now. So I've shown 4 techniques. One is conservative treatment. I've shown fixation in situ for undisplaced lateral condyle fracture, which are at high risk for displacement. I have shown a close reduction arthrogram and fixation with K-wire for patients who have a displaced lateral condyle fracture, which are reducible. And then we have shown an open reduction through a classical lateral approach and fixation for lateral condyle fracture, which are turned around, flipped over. So I hope delegates will find this very useful. If there are any questions now or later on, questions are part of life. I am having a lot of them now, but please feel to ask me later, anytime. Thank you, Varun, for taking me through this journey. Thank you very much.
Thank you.
Great show,
Excellent
Taran.
job. Absolutely to the point and very clear cut. I'm happy to say that Dr. James Wee from Singapore has also joined in. So we have a very elite audience and we'll welcome any questions for Taral at this stage. Delegates, please type in your questions into the chat box.
So, Taran, let me just initiate the discussion, if you can hear me.
Yeah, please ask.
Yeah.
Sandeep.
So a lot of times, though, you get this type 1 fracture with minimal displacement or no displacement. And on the follow-up, it's not displaced, but the fracture line remains persistent for quite some time.
Yeah.
Even after 6 weeks, you see that the fracture line is still seen.
Yeah.
So what is the time that an average orthopedic surgeon should start panicking?
Yeah. So we've done a study of these now, all undisplaced lateral condyle fractures. I'm happy to share that you should wait. You should wait at least till 3 months. For
3 months.
If the fracture is undisplaced in AP, lateral, and oblique, all the 3 planes, if fracture line is not widening, but if it shows delayed healing, just hold on with plaster and it will heal. In fact, I remember one patient where someone else had treated. Fracture line was persistent at 2 months, and we were trying to fix this fracture. COVID came, and then patient came after a month, and by that time the fracture had already healed. What you should look for is a soft callus on the lateral side, Sandeep. If there is the fracture line is evident, but if there is soft callus on lateral side, and if fracture doesn't have much movement, then you can still conserve it. If, however, if that fracture goes for non-union, it's very simple to just fix it with a simple screw, even at 6 weeks or
So
8 weeks or 12 weeks.
When will you start rehab for these children?
Rehab?
Because 3 months is a long
once
time for them to become in faster, so they start getting stiff. So what is the confidence?
6 weeks, 6 weeks. So I put a soft slab, removable slab, so in and out of the, but I still protect them. I don't want to have them to have uncontrolled movements. So we give a plaster, bivalve the plaster, in and out of the plaster, do the mobilization and put the slab, put the plaster back. That's what I would do. So what plaster I've removed at 6 weeks, I convert into a cast brace.
Okay, and you should monitor them for at least 3 months.
100%. So I've done CT scan, MRIs, but in all those patients who have delayed healing, like ulnar fracture, many ulnar fractures heal delayed. A lot of lateral condyle fracture heal delayed, but you must persist and you must follow them up till the time union is complete. At 3 months, if they don't unite, 3 months, then I would put a screw.
At 3 months, you will start considering putting a screw.
Put a screw, yeah. Because beyond that, I don't think they will heal up. There is no attempt at union at 3 months, then they will not heal.
In situ screw, you will start.
Yeah. What's your opinion, Sandeep?
No, I'm just asking for the general orthopedic surgeon because see, what happens is that most of the centers all over the country, they don't have digital x-rays. They don't have internal oblique views. We have clarified enough number of times that internal oblique is the x-ray to watch for. And actually calculating the medial gap, lateral gap can become challenging to a lot of people because I think general orthopods are going to treat this. So how do we instill confidence in them that you can?
So I think we're planning to write this up. I think I have time right now. I'll write this up about our algorithm for lateral condyle fracture. And there is a lot of clarity created recently. I call it as COVID clarity because there were some fractures we could not operate and we could actually see the natural history. The same patient at 6 weeks, there is no union, I would have put a screw. But just because of COVID thing, we held on, and then a lot of patients we saw they're healing up at 3 months if there is no displacement.
So I think
a question from me, Taral, what do you think of the configuration of the K-wire and screw construct? Do you prefer to put them collateral as you've shown, or in what situations will you use the Y that we talk about so often?
Depends on the fracture. If the fracture is so no lateral condyle is of same anatomy. There are short lateral condyle fractures where you have to have divergent screw fixation. Then there are longish lateral condyle fracture where you will have two wires parallel to each other. And then as Sandeep has shown, even Maulin has shown, the fractures which go almost medially, you will have to put three wires which are in different configurations. So, it's a 3D fracture. Study the fracture and you may have to decide on table your K-wire fixations or addition of a screw. So don't go with a known notion.
Yeah.
It's important that
I think I can hear you loud and clear for general orthopods all over the country. A long follow-up is very important in lateral condyle.
yes,
Never discharge the child till you are reasonably convinced that fracture is healed and will not displace. Dr. Meena, I think wants to say
Yes.
something.
Yes, Taral, good afternoon, and thanks God that you are in front of all us. We are really happy to see your smiling face and healthy face. Thank you. One thing I want to know, in some patients, in many patients, due to mild infection, wire come out in the plaster or during the dressing. In that case, is the another wire should be put or supplemented with the remaining wire? Or we have to continue with whatever wire remain inside?
No. So a loose fixation will not work here. So what you need to do in that case, if there is an infection with a loose wire, remove the wires, send for scab, start antibiotics, and definitely pass through a fresh skin, additionally two more wires, and monitor that child, because K-wire infections in a supracondylar or lateral condyle fracture can be disastrous. We should not let it happen.
We have seen many cases.
Yeah, but if it happens, no. So one of the ways to prevent it, when the residents do it, avoid multiple punctures. And always remember, the cartilage has to be pierced and bone has to be drilled. Cartilage doesn't have to be drilled. By drilling the cartilage, you are making it weaker. And weakness, a poor hold of a K-wire leads to infection. If the K-wire hold is good, then it will not lead to infection.
Now move on to the next speaker. Shall we, Sandeep?
Yeah, sure. If the time is up.
Yeah. Maulin, I think you can, while you're anyway, he's on. So I thank Taral on behalf of the entire team and request him if he can still stay on for some more time to keep poking us with questions. So we now move over to a very talented, young, dynamic pediatric orthopedic surgeon from Ahmedabad, Dr. Maulin Shah.
Okay. So, thank you, madam. And okay. So I'm opening the radial neck, but it is chronic. So I'll take chronic Monteggia surgical technique first. Hope I'm audible to everyone. Yes. Okay. So chronic Monteggia fractures are challenging for even trained.
Maulin, go full screen. Maulin, go full screen.
Oh, isn't full screen? I see the full screen. Mm-hmm. Just a moment. Can't you see the full screen, Premal bhai?
No, sir.
No, it's not.
Go to slideshow mode.
Slideshow mein ja.
Start the slideshow.
Maulin, you are sharing the wrong screen. You are sharing you are seeing a different scheme.
Okay. So maybe.
Yep.
Now
it's okay.
Yeah, you're on.
Yeah. So, thank you. So chronic Monteggia reconstruction is at times even problematic for trained pediatric colleagues, and we should go stepwise in reconstructing them. So such injury which presents say about few months after ORI index injury of say 3 months, 6 months. So one, you can see the plastic deformation of ulna. The first and foremost thing is to take a full length X-ray. Whenever you see an ulnar fracture in the forearm, try to take an full length APN lateral X-rays and just rule out the anterior dislocation of radial head. And we know that the radiocapitellar relation is a very important landmark, and radiocapitellar relation should be maintained in all the views. And some people have used this a line across the dorsal border of ulna, and if you have a lot of gap in that, you should suspect that and make sure that radial head is in position. Now I'm going to talk about chronic Monteja reconstruction. So this boy was presented about 9 months later, and in nutshell, the technique is you have to use a posterior lateral extensile Coker's approach. Many people have tried and used just putting an external fixator after doing an ulnar osteotomy and gradually distracted and flex the fragment. But there are high rates of redislocation and complications. So we have moved away from that, and we have tried and perform a conventional open reduction of radial head and followed by ulnar osteotomy if required. So typically it requires a posterolateral expansile Coker's approach. And once you take this approach, the first step which I use and which I learned from Peter Waters is to go through brachioradialis and brachialis interval to decompress the posterior interosseous nerve, because in his early experience he found some of the nerves were tethered or adhered to the radial head, and that's why he liked to release that from the muscular side, not touching the nerve more. That's an optional thing, but I have continued that practice. And once you decompress the nerve, you go through the Anconius and ECR interval, and then you have to approach the radiocapitellar joint and clear the radiocapitellar and radioulnar joint and look what is happening at the annular ligament. Most of the instances, what I have found, and we have found that the radial head has buttonholed through the annular ligament, and the more time has elapsed from the index injury, that buttonhole has become very narrow, and you can visualize the radial head, you can visualize the annular ligament, but the space through which the radial head has gone in front is very narrow. If it is buttonhole, then you can make radial incisions and you can widen the annular ligament. The mistake which we have seen, usually the fellows and colleagues, they just approach the top of radial head. What I do is, once I see the radial head, I go little proximal to it and see the actual capsule, and you will find a dent in the annular ligament, and then you pass your freer or periosteal elevator and maneuver the radial head in its position. And if you think the space to bring it down is narrow, you can make multiple radial cuts. Sometimes we see that the annular ligament is completely torn, and in that time we have to suture it. And in a very long-standing cases where there is no identification of annular ligament, people have suggested annular ligament reconstruction or Bell-Towsey procedure. In my practice, I have seldom required, and in fact, I have never done it because it was never required, but it has been mentioned in literature. Now, how buttonholing of radial head will look like? You can see this picture nicely drawn by John Ogden, and I see every time when I do this case, similar picture. So the whole annular ligament lies over the radial head. You will see the radial head, but you don't cut anything here. You try to milk this torn annular ligament over the radial head, and you have to bring it. The mistakes which I used to do earlier is, once I see the radial, I try to cut here and here and try to bring the head down, but I would now go proximal and try to find out a rent here through the annular ligament and bring it down. This is an example of torn ligament, and then one can take a couple of sutures there. Don't make those sutures very tight because that can lead to stiffness. And there's a case of Atul Bhaskar. He has done Bell-Towsey procedure in one of his cases through the triceps fascia, which usually is not required in most of the cases. Now I'll take you through the surgical technique video, and then I would like to answer if any technical questions are there. Fixation of ulna is the last but very important step when we go through the ECR and ECU interval. and do a flexion distraction osteotomy. Sometimes you can template how much of distraction you need. What I tend to do is once I do ulnar osteotomy, I reduce the radius in front of capitulum and I put a temporary thin K wire in a 100% reduced radiocapitular joint, and then see what is the situation of ulna. And in that position, I fix the ulna and then remove the wire. We do not put any transarticular wire because there are instances when it has broken, it's very difficult to retrieve. So never put a transarticular wire. One can use a simple reconstruction plate or semitubular plates. If you are using semitubular plate, try to use stacked plates at times, because semitubular plates contour goes off by the time you fix the ulna. So you can choose to use stacked semitubular plate. And the important thing is confirm your reduction under image intensifier. We have a tendency to confirm the reduction in only flexion and be happy that, oh, this is nicely reduced. But remember, when you extend, the long head of biceps is inserted on the radial neck and it will pull this radial head in front. So your reduction should be 100% in full extension, and then it is a nice reduction. Otherwise, you will see some degree of redislocation once you remove the plaster off. So the last step is to confirm your reduction under image intensifier in full range of motion. So let's go through the surgical video of one of such patients. So this was a delayed Monteggia fracture dislocation in an 8-year-old boy who sustained an ulnar fracture before a year and was treated conservatively. This boy presented with an anterior bump along the elbow crease, as you can see on the right side, which is very evidently visible on the lateral profile, and child also had a bit of hyperextension. And his elbow flexion was restricted, and you can see ulnar anterior bowing. So ulnar deformation you can see. On a comparison X-ray, you can see there is anterior displacement and there is mild calcification around ulnar ligament. And there is, you can see the AP view also. These are again comparison views. So we took then Coker's extensile approach and
Coker's incision, Coker's extensile approach. This is lateral epicondyle.
Let me see how we can.
In front of that is capitulum. There is an interval.
So one has to take this approach, and it should be centered over the lateral condyle, and you go through the Anconius and ECR interval. The first thing is, before this interval, I go in the front and go through the brachialis and brachioradialis interval. So you have to go a little bit anterior, and you can readily see the posterior interosseous nerve. And once you see the posterior interosseous nerve, you can release it from the muscular side. So you don't need to touch it completely, because we always have been taught that once you touch the nerve, it will go off. But I have seen in all these patients, it doesn't happen so. Once you do the open reduction, then you will find the annular. Now the white structure in the center is an annular ligament, and beneath that is the cartilaginous radial head. So now I'm milking this annular ligament down over the radial head, as you can see, and you will see nicely in the top view. And that part, I had made some cuts in the annular ligament, and radial head is reduced in the radiocapital. So this is how it lies, and then you have to milk this radial head down like this. So this is how annular ligament, and the radial head comes in front of capitulum. But then you will see that the radial head remains a little bit anteriorly subluxed, and so you understand that this child would need an flexion distraction osteotomy. In this case, it required only a flexion osteotomy fixed with a double stack plate, and we confirm the reduction in full range of flexion and extension and pronosupination, and that confirms that that radial head is sitting well. So you don't need to put a transfixing wire. And again, confirm this reduction in image intensifier. And you can see in full flexion and extension, this was reduced. Some of this, and this is a clinical and radiologic follow-up with longer term. The child has got full flexion and extension, and he has full supination, and there is mild restriction in terminal pronation, but he has done well. So this is how we fix a chronic Monteja fracture dislocation. Yeah, so if we have time, we can take questions here. Madam?
So Maulin bhai.
Yeah, we have time for 2 questions.
Hello.
Yes.
So how late will you attempt this kind of reconstruction? If the child comes with neglected Monteja 3 years, 4 years, would you?
Yeah.
So Sandeep, your voice is very soft. You'll have to speak it louder.
I am a soft-spoken person.
So yes, Sandeep, we know there are some papers. One of them was from Boston Children's and they have seen if we tend to operate beyond the 3 years of index injury, the rate of complications like resubluxation, stiffness, and infection that increases. So the landmark is up to 3 years. We can try and reduce it. After 3 years, we should not, because that is associated with high complication rate. Seeing that there are some patients who have progressive cubitus valgus and pain, and with every attempt at flexion. So I require to operate upon a boy after 8 years of index injury. But we have to tell families that if we operate them after a pretty long time, they would end up into stiffness. Mainly the forearm rotation may remain restricted. The only purpose of that intervention would be to prevent progressive cubitus valgus and related delayed effects.
Yeah. That's right. So it's been said that 3 years after that, after 3 years, usually what happens is the radial head overgrows and it becomes deformed. I don't think it's a problem of infection or anything, but it's arthritis and losing range.
Yeah.
But as you rightly pointed out, sometimes it's important to put it back even then because valgus instability is difficult to treat.
Right.
If there are no questions, Rujita,
yeah, we can move on to the next one. Can I now invite Dr. Jayant Sampath, our illustrious.
Madam,
yes.
My radial neck thing is left, no?
But we've already come to 20 minutes. So what we'll do is you keep it in abeyance.
Oh.
We'll come back to it depending. At least let's cover each speaker once.
Okay.
Yeah. So it's very nice and we would definitely like you to show that. So Jayant, may I request you, our CP man from Bangalore and we're veterans pediatric orthopedic surgeon, to start without much ado now.
Can you see my screen, Rujita?
Yes, we can.
So thank you very much to Dr. Rujita, Dr. Meena, and the entire organizing team for this opportunity. I'm going to talk about 2 common procedures that are done for children with cerebral palsy. So the first is the gastrocnemius recession, which is an extremely common operation. This is typically done in children with bilateral cerebral palsy or diplegia. It's important not to operate for spasticity. Spasticity will reduce by the age of about 7 years, and gait also matures by the age of 7 years. So do not operate on 4-year-old toe walkers, because those children need non-operative measures like botulinum toxin injection, splints, and physiotherapy. So these operations are meant for the older child where they have a problem with contracture. And if in doubt, do not operate, because if we over lengthen the calf, then it causes significant problems later in life with the onset of crouch gait. But even appropriately performed gastrocnemius recession will weaken the calf. So it is a bargain that we are making in that we are allowing the calf to become weak in return for allowing the child to have a more functional gait pattern. 3D gait labs are now available in all corners of India. So I would recommend that every surgeon who performs an operation on a walking child with cerebral palsy should obtain 3D gait analysis if at all possible, because it massively improves your comfort and the quality of your decision making. So there are 5 levels at which the tendo-Achilles mechanism, the plantar flexors can be lengthened. Level 1 is close to the insertion. This is a ZUD lengthening or a hook. These operations should not be done in diplegics. These are mainly meant for hemiplegics. Level 2 is a Baker, which is done at the musculo-tendinous junction. Slightly more proximal are the vulpius and the stria, and I will be showing you a video about the stria. And then you have a higher level, which is on the muscle fascia of the gastrocnemius, or you can detach the gastrocnemius from its origin, the medial or the lateral heads, and this is called the Baumann procedure. So this is a video that I recorded some time ago showing the gastrocnemius recession. This is the Silver-Sciol test that we perform under anesthesia so that there is no spasticity. You can see that there is a calf contracture with the knee in extension that is abolished by knee flexion. So the skin incision is just made where the gastroc muscle belly is seen to gradually disappear into the fascia, 2 fingers breadth posterior to the posterior border of the tibia. This is a fairly safe corridor, so one can use sharp dissection and incise the deep fascia of the calf in line with the skin incision. So once we go through the deep fascia, we use finger dissection to sweep the loose areolar tissue between the deep fascia and the gastrosoleus aponeurosis that you can see. That's the silvery white fibers of gastrocnemius aponeurosis, and then more medially, where my knife is going, you can see the soleus aponeurosis. You can see the muscle coming through, and that is the lower end of the medial head of gastrocnemius. If you want to do a more proximal pure gastrocnemius lengthening, you can get into that gap that I'm going to show you in a minute, where my knife is going. You can see that gap. So you can again dissect with blunt dissection in that gap, but I do it at a slightly lower level where the gastrosoleus fascia is already merged. And then you start all the way from the lateral border, use a retractor to protect the sural nerve that comes between the 2 heads of the gastrocnemius and goes laterally. And then you just make a single stripe directly across, but do not forcibly dorsiflex the ankle, because again, that will over lengthen the calf and weaken it. You should very, very gently extend, dorsiflex the ankle and extend the knee only up to neutral. So do not forcibly dorsiflex the ankle. So the post-op regime is a below knee weight bearing cast. Child can start weight bearing after the surgery immediately as tolerated. So I put it on for 4 to 6 weeks, 4 weeks in children less than 10 years and 6 weeks in children older than 10 years. Because the gastrocnemius is a muscle that crosses the ankle and the knee, some form of immobilization above the knee is required. So I use a knee gaiter at night time for 8 hours, and this is continued for a period of 6 weeks to 3 months. And AFO is mandatory for a minimum of 1 year post-op, possibly longer. The commonest reason for recurrence of contracture after gastrocnemius recession is failure to comply with the ankle foot orthosis. So it's very important to reinforce this after surgery. And obviously a prolonged program of physiotherapy is required after any operation in a child with cerebral palsy. Moving on to the next procedure I'd like to discuss. This is the hamstring transfer. It's a relatively new operation which has come to the fore in the last 5 years. So this is largely amongst surgeons who perform a lot of cerebral palsy surgery. The hamstring transfer has replaced the hamstring release. So you will know that the hamstring is a hip extensor in addition to being a knee flexor, and complete release of the hamstring, even a complete medial hamstring release, causes excessive anterior pelvic tilt because its function as a hip extensor is lost. So these children after surgery, they develop lumbar hyperlordosis and lower back pain. And again, a humble plea to all surgeons to use 3D gait analysis for decision-making pre-op. If on 3D gait analysis, you find that there is a lot of anterior pelvic tilt pre-operatively, one should be extremely careful with performing a hamstring release, because this will increase the amount of anterior pelvic tilt after surgery. So 3D gait analysis is probably even more essential the more proximal your surgeries in a child with cerebral palsy. So this is an example of someone who has had an over lengthening of a hamstring. This was a functional walker with a little bit of knee flexion, underwent over lengthening, percutaneous hamstring release was done, and you can see post-op that he's gone into severe genu recurvatum, and you can see the amount of anterior pelvic tilt and the lumbar hyperlordosis, and these children eventually will stop walking. It's disastrous for the child because once you over lengthen the hamstring, it is irreversible. So moving on to the surgery itself, it is done in the supine position. The original hamstring transfer was described in the prone position, but we have developed a technique by which we can do it in the supine operating position. So we check the popliteal angle pre-op, and you can see that this child has a 90-degree popliteal angle. His gait showed that he had a persistent knee flexion in stance. So that's the gracilis and the semi-tendinosus, semi-membranosus. So the incision is between the gracilis and the semi-membranosus, just above the knee flexion crease in the posteromedial aspect of the knee. These operations are done under tourniquet control, just for better visualization of the anatomy. So the first muscle that I'm isolating here is the semi-tendinosus, and then immediately medial to that is the semi-membranosus. So the semi-tendinosus tendon is identified, and with blunt dissection, it is isolated from its surrounding paratenon. Next, the semi-membranosus is identified, and this is the gracilis. So we perform an intramuscular tenotomy of the gracilis, and then this is the semi-membranosus. Sorry, the video is a little out of focus. It will come back into focus in a minute. So I'm just carefully going into the sheath of semi-membranosus and identifying it. Next, using a McIndoes, we release the semi-tendinosus wherever you can see the end of the tendon at the bottom of the incision. It's not necessary to go all the way to the insertion of the semi-tendinosus in the pes anserinus. So here you can see a clearer view of semi-membranosus, and we just do a myofascial recession. Again, it's important intra-op not to do a popliteal angle. Should not repeat the popliteal angle test after releasing the medial hamstring muscles, because that could overstretch the sciatic nerve. So this is the tendon of adductor magnus, which is clearly palpable just anterior to gracilis. And then we put a right angle forceps to go around the tendon of adductor longus. This is easily identifiable because it inserts into the adductor tubercle of the distal femur. So it doesn't matter. A lot of people ask me in what amount of knee flexion this tendon transfer needs to be tensioned. The amount of knee flexion is not really critical because this is a soft tissue to soft tissue transfer, and the tension will adjust. The tension is only important when you're doing a tendon to bone transfer. And one more stay suture is applied, which goes through the semi-tendinosus and then through the adductor magnus. So another point is that one should not do, after releasing the hamstrings, one should not do a popliteal angle. So you should not stretch the tendon. You should do it in a very gentle manner. So after hamstring surgery, we can allow the child to weight bear as tolerated immediately after surgery. We do it as little as 2 to 3 days after the surgery. A knee gaiter is used at night for 8 hours for a period of 6 weeks to 3 months again. A gaiter is always used for standing during the day until quadriceps control is regained. And unsupported weight bearing without a splint on the knee, you should not allow the child to weight bear unless until they are able to get complete extension of the knee in standing, because it's very common for children to go back into the flexed knee position again, and it takes them a long time for their brain to readjust to this new pattern of weight bearing. So It's important to emphasize to the therapist that they should keep some splint on the knee until the child themselves can lock the knee in full extension and stand, and only after that we allow them to start weight bearing. And anti-gravity muscle strengthening exercises have to be continued for at least 1 year after surgery. So thank you very much for your attention.
Excellent, Jen. Thank you for finishing absolutely on time. We have time for a few questions. Since we have the privilege of James, who is also from Singapore, logged in with us. Any comments from James? Okay, maybe we can ourselves initiate a discussion. Jen, are there any typical contraindications you would want to tell the general orthopedic surgeon that in such a case a hamstring transfer is a strict no-no?
So again, this is a surgery which is performed in walkers, in people who have some potential for functional walking. So these are the GMFCS levels 1 and 2. GMFCS level 3 is a child who's walking with a walker or with some sort of support. So one needs to be a little bit more careful in doing hamstring releases or even hamstring transfers in the children who have a lot of weakness. So the weaker they are, the weaker the child, the more careful one needs to be with muscle lengthening surgery. And it's better to do bony surgery on them because bony surgeries, so it's better to allow these children to go into a little bit more crouch. And if they go into crouch and they are not able to stand in adolescent years, you can do a femoral extension osteotomy. That is a more, bony procedures are more reliable and they have, can I say, less unpredictability compared to soft tissue releases. Allow the child to completely mature. So do not do surgeries on children less than 7 or 8 years of age. So wait for the gait to mature, wait for contractures to develop, and then we have to do surgery because most of these operations are not reversible. So you cannot go back. I mean, you can always redo it. So if you underdo a CP surgery, it's very easy to go back and redo it. But if we overdo an operation in cerebral palsy, it's very difficult to undo the effects of surgery. Surgery is a very powerful tool. So one needs to use surgery in cerebral palsy with extreme caution. But in the right patient, carefully selected patient, ideally with 3D gait analysis to guide our decision making, I think the surgeries I have shown can have very gratifying long-term results. Important to follow it up with good amount of bracing and to have a good pediatric therapist who is backing you up and who will support you. All the surgical efforts that we do needs a lot of backing with good physiotherapy. So these are not one-off operations. You need to follow these children up over a long period of time. You need to understand the child, the family, and take several visits. Follow these children up at least for 1 or 2 years before you start operating on them.
I think the only comment I'll make, Jayant, if you can hear me. Can you hear me?
Yes, I can hear you, Sandeep, please.
Sure. So because you titled your talk hamstring transfer, I think you have to say that or mention that lateral hamstring is not to be touched. Second, absolutely, you are doing partial fractional lengthening of 2 hamstrings and it's only the semi-T that you are transferring.
Yeah, there is a school of thought primarily being propounded by Paolo Selber, who's a very eminent CP surgeon, that he does only hamstring transfers. So in fact, we have a collaboration through POSI where we are planning to do some randomized trial comparing this medial hamstring lengthening with hamstring transfer with a pure hamstring transfer, just transferring the semi-T and not touching any of the other tendons. So this is a sort of a procedure which is in evolution. So at present, when I compare my patients, because I used to be releasing semitendinosus or ZUD lengthening semitendinosus, compared to that previous group, the current group where I'm attaching semitendinosus to the adductor magnus, the amount of anterior pelvic tilt is a lot less. Because
so how do you quantify in what tension are you going to suture the semi-T?
That's what. So the tension doesn't matter so much because it's a tendon to tendon, it's a soft tissue to soft tissue transfer. So it adjusts itself. But I would, I have tensioned it. I typically tension it in slight flexion, maybe 30 degrees of flexion, just an easy amount of flexion. Okay. But there isn't any particular, that's not been quantified. But in about 30 degrees of flexion, if you tension it, I think in my hands, I've been doing this for 5 years now, and we have pre and post-op gait analysis in about 20 patients. And we have shown that the anterior pelvic tilt that we used to have prior to introduction of therapy, that is a lot less. It is not abolished completely. There is still some anterior pelvic tilt, but it is not disabling high.
Yeah, the flexure tightness and extensor weakness also contribute to that.
Sandeep, if I can add to this, I think you asked about the tension. Basically, this transfer, what it means is that you are removing one of the knee flexors and converting into a helper of extensors. So what happens is when the semi-T flexes along with the hamstring, it actually pulls the knee back and helps the quadriceps to extend the knee. So that is.
I think it's just a restraint. It doesn't actively pull the pelvis back. It's a restraint from allowing it to fall over. But again, a tight anterior flexor and a weak hip extensor are going to change those dynamics.
No. It just pulls the femur back so that the extensors have a better lever arm. That's
it. Yeah, I think we can move on.
Yeah.
So our next speaker, thank you very much, Jayant, on behalf of the whole team. Next speaker is from Ahmedabad, a very, very veteran surgeon who is specially known for his trauma, but he's amongst the pioneers of pediatric orthopedics in Ahmedabad and practically well versed with almost every aspect of it. So, Premal, over to you.
Yeah, thank you, Rujita. I'm going to bring you back to trauma, our bread and butter, and the area of discussion will be arthrogram of elbow and hip joint. The first, we'll start with elbow. And before we start, I would like you to raise a question. And the question which came to my mind was that why do we need an arthrogram? And this particular case will elaborate you why do you need this technique to be learned. So this 2-year male was operated by an orthopedic surgeon who received this patient fresh within a couple of hours of injury. A beautiful close reduction and pinning was done, but unfortunately, when the wires were removed, the child had a significant cubitus varus, as you see in this X-ray. So what went wrong? Basically, what happened in this case was the surgeon could not delineate the distal fragment. He could not visualize it properly. So he placed all the wires in the proximal fragments without any wire in the distal fragment, which slipped into varus and led to cubitus varus. So now the question arises how this can be prevented. So let's look at another case. 3-month-old female came to me. She had a previous trauma in the same limb. And this is how with this X-ray she came to me. With the traction films, the fracture was not properly visible. The distal fragment, which was absolutely cartilaginous, was also not very visible. So what I did was I put a small amount of dye so that the distal fragment was very well visible now. So with the visibility of the improved visibility of the distal fragment, this fracture was just reduced like a supracondylar fracture. One can see the reduction here in AP as well as lateral view, and it was simply fixed by 2 lateral K-wires, and repeat arthrogram showed nice articular congruity and a good reduction like a simple supracondylar fracture. And that is how there was a good union without any deformity. Again, this child, male 5-year-old, had a significantly tilted radial neck, but I could not see radial head properly. Even under anesthesia examination, I could not exactly see where the radial head was and how much angulated it was. The moment you put a small amount of dye, one can see that there is a significant angulation of the radial head, which is looking way away from the radial shaft. With joystick reduction, the radial neck was pushed back and there was an excellent alignment, which was stable throughout the range of movement. I did not fix it, but could get good peroperative and postoperative range of movements. So for those who do not know how to do this procedure, as Taral already mentioned, there are 3 ways of approaching elbow joint. One is from the lateral side, another is from the posterolateral side, and the third is from the posterior side. The most important thing, what our colleagues generally don't know what dye to be used is a contrast agent. It is basically a low osmolar dye, non-ionic, non-meric contrast medium, which is either iopamidol or iohexol. The commonly available trade name is Omnipec. Dose is not provided by the manufacturer, but in generally pediatric patient, you might dilute the Omnipec. There are certain iohexol dye which are coming in lesser amount of dilutions, more amount of dilutions where you can use increased quantity, but you should not use more than 2 milligram per kg body weight. But generally about a millimeter or 2 ml of dye would not exceed this dose. What you need is an 18 gauge needle. Approaches I've already discussed. Let's look at a clinical example. This 3.5-year-old male sustained trauma while playing. This is the time in which I was not aware of internal oblique x-rays. So what I did is I put the child under anesthesia, and this is how I would mark my bony points. This is the olecranon, this is the radial head, and this is the distal humerus. If you palpate, there is always a soft spot just lateral to the olecranon process. You can put a needle through that soft spot. In a trauma case, once you put the needle and if you are in the joint, you will have hematoma evacuated if this is a fresh case, and it will be mixed with joint fluid so that that hematoma will not be exactly like blood, but it will be thin blood. Once you have that, if you want to reconfirm, you can inject a small amount of dye so that you are sure that you are in the joint. It may not be necessary if you get nice hematoma evacuation as seen earlier in the video. And then you can inject, and during the injection, you should watch live so that the exit of the dye will tell you where the fracture line is and whether there is a capsular tear or not. So if you look at this, this is the significantly displaced fragment of lateral condyle, which was looking seemingly undisplaced, as Taral mentioned, what he calls as sulta. And this required open reduction and internal fixation and had uneventful recovery. Arthrography can be used in decision making in pediatric elbow as well. Classifying lateral condyle before the advent of internal oblique view, and if you're not sure if you have this type of fracture, you can do an arthrogram. If arthrogram shows that there is an extension of the fracture all the way to the joint, and this should be secured and stabilized with divergent K-wires percutaneously. It can be useful in neglected injuries. This child presented to me with stiff elbow. This was an injury in rural India, could not come to me in time, and that was the X-ray at the presentation. When I took a proper good quality X-ray and the true lateral view, it appeared that this was a neglected elbow dislocation. Somehow the things were not fitting well with my clinical examination, so I decided to take that child and put him, add some dye here. So when I did a dynamic assessment, I found that the elbow joint was very well located, but there was anterior fracture with anterior dislocation of the shaft. So basically, this in radiological picture, that was the humerus and this was the anterior bone. So this is basically a physeal separation which was missed and malunited, and the anterior bony shaft was probably jutting out and preventing the flexion. The child was advised to wait for remodeling and then take up for the surgery. So a small amount of dye, if kept handy while treating the elbow injury, can prevent multiple, can lessen the amount of surgical volume and sometimes allow you to make a clear decision without disturbing the sanctity of the elbow joint. You need to learn how to do these things, because this was a friend who sent me a case from his OT. This 2-year female had this type of injury and this MRI was there. I'm sure you can hardly make out what type of injury is till you look at all the films. In this lateral films, you can easily see that this is a physeal separation. But if you know how to read an elbow X-ray, you will be able to read this X-ray preoperatively and will not even need an MRI. So what happened was this child had an arthrogram, but the dye was so much dye was used, which there was so much of an extravasation that distal fragment clarity was not there. So this gentleman had a difficult time while reducing and fixing this. And that is the simple example I wanted you to see, that if you start doing this arthrogram in relatively simpler cases, you will get the hang of the technique. And when you really need that, you will have mastered that technique. That is how we did it. So basically, elbow arthrography, I would say, is must for all the orthopods who treat children with elbow injuries, especially if you are treating really young children, less than 2 and 3 years old. This is a great handy tool which helps in making your decisions with clarity. It avoids unnecessary surgery and exploration, decreases complications, and I have found that few ml of dye solves many complex problems. Moving from elbow to hip, I would classify the use of dye in a cold as well as traumatic cases of the hip joint. As always, we'll start with trauma. This 2-year-old male fell from a second floor and presented to me with this two X-rays of the entire limb. The problem this child had, he had a normal CT brain, but he could not move right lower limb, and this was his Scott film on the pelvis. And when I saw the child and when I did a lateral X-ray, it was very obvious that there was a capital femoral epiphysis separation or type 1 Delbey injury to the proximal femur. So the treatment is basically very simple. You take the child under anesthesia and then you stabilize the physis. The best way to stabilize physis is to use smooth KYs. So I put 3 smooth KYs, and to confirm that there is no joint penetration by the KY to prevent any type of chondrolysis, it's best that you do an arthrogram and confirm that all the wires are within the limits of capital femoral epiphysis without any migration inside the joint. This is the 1 month and 2-year follow-up radiograph of the same child and an excellent clinical result. The same thing is there for SCIFI. In this lockdown, as Tarun mentioned, that there is a difference in the way we see the injury pattern. We are seeing a lot of neglected cases. And what I'm seeing is a lot of kids who remain homebound have put on a lot of weight. They are deficient in vitamin D, and there is a significant increase in the ratio of slip capital femoral epiphysis, which I see currently in my practice. So this child had SCIFI pinning a few days earlier. And when I put the child through the range of movement, I found that there was a significant less distance between the screw and the margin of the hip joint in these 2 particular views. So to confirm whether there is any penetration or not, I did an arthrogram, and after doing a dynamic assessment, it was obvious that the screw was significantly away from the articular margin. It had not caused anything, and this patient has a very less chance of developing iatrogenic chondrolysis. Let's move on to non-traumatic conditions in the pediatric hip, where the arthrogram will help you in making a diagnosis and make the life easy for an orthopedic surgeon. This 11-month-old female presented to me with diagnosis of DDH. Mother noticed shortening and the X-ray was done, and this is how she had missed the bus of significantly less severe treatment and ended up to an orthopedic surgeon for an invasive procedure. So this child was reduced like this, and there was a very nice cone of safety, which is called a safe zone or safe cone of Ramsey. And we decided that we'll try and do conservative treatment. But before you try and do conservative treatment, you would like to be sure that you have achieved a concentric reduction. So the best thing to do is to do an arthrogram. There is a medial approach to do hip arthrogram in infants. You take an entry just below adductor longus tendon, direct it slightly laterally. You hit the femoral neck, and you are generally in the joint. And then you can inject the knee dye with live fluoroscopy on, so that you know that you are in the joint. Similar to elbow, you can use a small amount of air to confirm that you are within the joint or not. What is most important in hip arthrogram, again like elbow, is how you interpret it. Basically, if you look at this arthrogram, you can see that this is the capital femoral epiphysis, which is very well delineated. This is the femoral neck with significantly increased anteversion. This is the femoral, the hip joint capsule with ligamentum teres, and this is basically the part of the labrum which is there between the head and the acetabular margin. And once you reduce it, you can see very well that there is no dye pulling here, and this thing which we call known as the labrum is completely out, and it is not obstructing the reduction. And there is no medial dye pulling, which suggests that there is an excellent congruity of the hip joint, and this hip joint is likely to remain stable and give excellent clinical result. Post-reduction CT shows a good confirmation of our good reduction, and this is a 1-year follow-up with excellent clinical results and radiological results. You are not always successful with your close reduction, and you need to know where you will not be. So this girl with bilateral DDH with one side dislocation and one side dysplasia was referred to me. Under anesthesia, I did an arthrogram. So in arthrogram, I found that there was a significant tissue, that is this labrum was posed between the head and the reduction. So when I reduced this, I found that the labrum was actually coming between the head as well as the acetabular floor. So if you interpret this arthrogram, it very well shows you that that is the labrum which is infolded and it is not allowing the femoral head to gain access into the floor of the acetabulum through the acetabular cavity. And there is a significant medial dipooling which suggests that this reduction is not concentric, even though the femoral head appears opposite the acetabulum. So I went ahead, did clearance of the inverted limbus from the medial anteromedial approach. Now the femoral head is sitting very well against the acetabulum. This is the labrum which was inverted, which was slightly incised and everted. This is the size of the incision you can generally get away with if you're using anteromedial approach, and child did well. In very complicated conditions like complications of femoral neck fracture, this 14-year-old female fell at home and had fracture of neck femur. She was advised by an orthopedic surgeon for stabilization. So they could find out one orthopedic surgeon who advised that this can be treated with traction. So child was put on traction at home, and when she resumed movement, there was a significant restriction of movement. So a couple of months down the line, child had this radiological picture. There was this was the amount of the movement she had when she presented to me. And when I did an arthrogram and did a static evaluation, I could realize that something wrong is happening. The beauty of arthrography is to allow an dynamic assessment. So when I did a dynamic assessment, I found that there was a hinged abduction, which you can beautifully see in this radiological picture. And there was a mushrooming of the head, which you can see by rotation of the femoral head. So this child was then treated. This is after draining the extra dye. One can delineate the femoral head very well, and one can see that the head is impinging against, the furrow in the head is impinging against the lateral margin of the acetabulum. So she was treated with broomstick POP with medial tenotomy. She initially did well, but unfortunately she slipped back. She was advised some further procedures, but she did not follow. Another case, 10-year male who presented 2 years down the line with a diagnosis of Perthes hip, again had restriction of abduction, and even without arthrography had a hinged abduction, very obvious on dynamic assessment. So this child had undergone arthrogram to see in which position the head comes out, and there is a nice congruity. So if you look at this video, in adduction you will find that there is no medial dial pulling. In adduction there is no medial dial pulling. In abduction there is a medial dial pulling. So if you adduct the proximal femur, it articulates much better with acetabulum. So this child was then operated with adduction osteotomy of, that means the valgus osteotomy of the proximal femur, and this is his clinical result at 1 year follow-up. I was supposed to take another topic, but due to lack of...
No, I think, yeah. Only 2 minutes left, so...
Yeah.
Hopefully, if Dil Mange more, then we'll do one more of these programs.
So this is, I have this on my YouTube channel. One can watch that, and I would like to thank you with this word, this simple word that the world changes when we change our own perspective. Thank you, Rujuta, and thank you, everybody.
So Sandeep, we'll just have 2 quick comments, and then with that, I will ask you only to continue with your talk. Sandeep is our current Pediatric Orthopedic Society Secretary, and very, very learned and very experienced senior pediatric orthopod.
So, sir, Premal, that was excellent exposition of various kinds of cases. Just a couple of questions for from the general orthopedic point of view. Have you seen any allergic reaction to these dyes?
Sandeep, you are soft spoken again.
Have you seen any allergic reaction to these dyes?
No, not yet. But I think these are all non-ionic dyes, and the rate of reaction is much less. But it is always good to do serum creatinine before you do this, and which is generally a part of preoperative profile, as these are done under general anesthesia. So they are all pre-investigated for that.
Safe.
Okay, Sandeep, I cut in here because since Rujuta said that, I just stay quiet. Premal, I think one small point to highlight to all the participants was, you see the difference between the contrast you put in and some of the example that you show other people was really, I think initially the contrast should be as small a dose as possible, because one of the common mistake for people who do it is they're so worried that they didn't show enough, and then they inject, and then in the end, they're a mess. Yeah.
Yeah. So that is the reason I chose that case, to show that in a small child, you need a right dose to be injected. You can always re-inject it if you need.
So the second question is, how long does the dye remain? Because for a learning curve, people will have a learning curve, right? If it extra visits, how long they should wait for that to disappear so that they can try again?
So Sandeep, from joint the dye disappears much earlier, but from the soft tissues, muscles, it takes a long time. So I think it may, if you're not conversant with, I think you may have to abandon the procedure, because if it's just
so those who are just starting off, would you advise just do a air arthrogram, confirm you're in the joint, and then?
Absolutely. A small amount of air within the joint will not cause much problem unless it is pushed under significant pressure. I think there is single report of air embolism, but I think the dose of the air used was much more. So small amount of air, or you may use a saline which comes back, which confirms your entry in the joint, maybe a step which is you should, and try doing it in a bigger kids initially, and you get a hang of the situation, and then you can reduce your age limit.
All right. Thank you.
Thank you.
So Rujuta, shall I go on?
Yes.
Okay.
Yes, absolutely.
Okay. So I hope I'm audible now.
Yeah, totally.
Yeah,
okay.
Clearly.
Yeah. So I'll just talk about management of acute unstable slips and the pitfalls and how I do it. So I feel a surgeon slips and falls on his face if he misses a mild slip, if he manipulates an unstable slip or a chronic slip, if he creates avian or chondrolysis, or leaves behind a large deformity which is going to cause arthritis. So an acute slip is an abrupt displacement to the proximal physeal cartilage in which there was pre-existing epiphyseolysis, which is about 10% of all slips. Usually you will have a short history of less than 2 to 3 weeks duration, but about 75% will have a prodromal history of about 2 to 3 months with a little limp or a minor trauma. So it's best to call most of them acute and chronic who have mild weakness or limp prior to that acute episode. Physically, usually the pain prevents examination, and you shouldn't be very aggressive or forceful when you are examining, but there'll be marked restriction of rotation, especially medial rotation. And remember, examination can make the slip worse, so try not to manipulate. Defining unstable slips has been really difficult. Lauder called clinically inability to bear weight as being unstable. On ultrasound, if there is effusion. On X-ray, if there is absence of metaphyseal remodeling. And intraoperatively, if you have minimal callus and it's highly mobile, then these are unstable slips. However, many stable hips have been noted to be unstable once you open them. The Klein's line is a useful line for all the general orthopods, where you have a widened irregular physeal plate, decreased height of epiphyses as compared to opposite side, and you draw the line. So don't miss a mild slip. And the frog leg view gives you a correct orientation of the slip. However, doing the frog leg can also be a little bit bothersome, or it may exaggerate the slip or increase the angle. The optimal treatment for acute unstable slip should be technically simple to minimize iatrogenic avian, minimize chondrolysis, should not leave behind residual deformity, and should not compromise prosthetic replacement for the future if it happens. So when does AVN happen? AVN is seen in unstable acute slips, over-reduction of unstable slips, trying to reduce chronic slip, putting pins in the superolateral epiphysis, or in cases where you had to do a neck osteotomy. Chondrolysis again has been seen with manipulative reduction, long duration of immobilization, realignment osteotomies, or pin penetration. So these are the two villains which we have to be afraid of and should not be causing them by ourselves. The slip angle of less than 30 degrees has a very minimal risk of AVN and minimal functional restriction. So the primary treatment that should be considered is an in situ pinning. And anterior osteoplasty may be considered in addition. So this is an example where an in situ pinning has been done on the left side, which went on to satisfactory healing, but you can see that there is a mild cam on the anterolateral head part. You can add an osteoplasty to address that in mild slips, where you can put an in situ slip. If you're good at arthroscopy, you can just burr it off, or a small mini anterior approach and trim that part so that you don't leave behind the cam deformity. Moderate to severe slips, what has become popular is the GANS modified Dunn procedure through a safe surgical dislocation approach. A transtrochanteric surgical dislocation, check the blood flow, and then take down the stable trochanter and resect the callus. So developing the posterior long flap is the key to preventing AVN. So this is a modified Dunn procedure through a safe surgical dislocation approach, which has gone to a successful outcome. Severe unstable slips, this is how it looks intraoperatively. And then this is how it has, after the callus has been resected and the head is reduced onto the neck. And that is how the reduction looks. My choice, however, has been inspired from Parsh and my comfort from the anterior part. His method of doing an open reduction with a smooth fixation for unstable slips. So the anterolateral approach and an anterior arthrotomy in unstable slips, which Parsh has published, where he got a partial reduction, reduced the angle, maybe resected a little neck and pinned it. So the safe surgical dislocation, which is becoming so popular, is it a panacea? There is a big learning curve. We have spoken to the experts and they say it's about 50 cases. The time for surgery is more, the blood loss is more. And the question why we call it safe is that did you really bring down the AVN rate? When you call it safe, it has to be safe. And what does the literature say? These are a few examples where it has been done and failed. Doing a shelf after that is no solution. This is again an example where the screws penetrated and broke. So there are problems which happen even with so-called safe surgical dislocation. If you look at literature published from the Boston group, complications of a modified Dunn's osteotomy, they had 37% complications and 15 revision procedures were performed. They found that intraoperative assessment of head perfusion does not correlate with postoperative AVN rates. And what they saw was when they did head drilling intraop, 5 patients, there was no bleeding, but only 1 underwent AVN. And 21 of them had brisk intraop bleeding, of which 9 developed AVN. So when you say that the head bled well, is no guarantee that AVN will or will not happen. It's pure conjecture. So what they have recommended is a high volume surgeon must be present doing the modified Dunn procedure, and they have modified their surgical indications. So what is the issue here? Is it disease determined AVN or surgeon created AVN? And what I thought was, can we make it simpler with the same results? So this is an example. We had a slip on the right side. He went away, did not accept treatment of surgery, and came back with a left-sided slip. And you can see the right side, how it has healed. So I'll just go through the steps of how I do it. I use the standard anterior Smith-Peterson approach. That's the interval between sartorius and tensor fasciae lata. That is the rectus femoris from the anterior inferior iliac and the capsule of the acetabulum, which is detached. So you detach the rectus, and after detaching the rectus, you start with the capsulotomy. So the minute you do a capsulotomy, you can see the hematoma draining off immediately in an unstable acute slip. So it's important that we keep the leg in external rotation. At no time should you attempt to reduce or internally rotate the leg. Do the surgery with the leg externally rotated. The preparation has to be in external rotation. No forceful internal rotation should be done till we have made the neck osteotomy. So after the capsulotomy, immediately what you see in front of you will be the neck. So I make a 1 centimeter cut anteriorly, and as you can see, I just lever out the fragment, and you can see that it is already detached from the fascial side. Once the gap is created, the tension on the capsule, the tension on the posterior retinacular flap is relaxed. Then I use a small curette and scrape off the residual cartilage from the head side also. The head is lying posterior. I haven't seen it yet. But what I'm doing is creating a gap, scraping off the head. Posterior flap has not been seen, but I take a small anterior wedge, which is not going to interfere. So this is the amount of bone that is removed. You can see it's a triangular bit. One side is where it is abraded from the fascial side, and this is the cut that I have made. So just to put it pictorially, this is the amount of bone I remove. It's not so big, it's a smaller wedge, but the posterior retinacular vessels, which are there, the anterior flap is already torn, as you know, with slip. But the posterior flap is intact, and this is the one which is supplying blood. So we take an osteotomy or a neck osteotomy anterior to that. It's a small triangular wedge, and we don't interfere or try to go in that region at all. And once that is done, the maneuver then is when the things are relaxed, you just gently flex the hip. Now the neck engages the head, which is lying posteriorly. Then I internally rotate and extend and bring this down. Now, when I do this maneuver, I've found each time that with the maneuver, the head comes back to its position. So you'll see when I do that on the C-arm, that's a longer shot or long view of what we are doing. And you see that the head has got relocated and the alignment of the head to neck becomes perfect. And now it's a simple matter of putting the pins from the lateral side percutaneously. So we can use a 32 mm or a full threaded. I use a stainless steel screw, a cannulated screw from Zimmer company. And at the end, as a routine, we do drill the head and see whether it bleeds. Again, as I said, we are happy if it bleeds, but it is no guarantee that AVN will or will not happen. That's just evidence of head bleeding. And that was the fixation. So these are the preliminary results of our 24 patients over the last 7 or 8 years, which we are writing up and publishing. So I won't go into the details for lack of time, but I'll just tell you that the anterior approach is a familiar approach to most surgeons because we use it for various surgeries in the hip. So our learning curve is already cut down. We do DDH from there. We do septic hip from there. We do osteoplasties from there. The capsulotomy decompresses the hematoma and relieves the pressure on the head. Then we are doing the neck osteotomy first, that's shortening the neck. Don't shorten it too much. Gentle reduction to correct the proximal femoral anatomy and fixation with cannulated screws through the front does very well. My average surgical time for this procedure has been 30 minutes. These are the results. I've had about 10% AVN rate in my series, and I've been pretty happy with what's happening. And I haven't seen the need to go from the safe surgical dislocation point so far. So I've been continuing to do this. And I think for the general orthopod or to the newbie, I think this is a very good approach. This is a case where we had AVN, sectoral AVN. We removed the screw, and over a period of time, he's done well eventually. So I think the anterior approach is a familiar approach with a shorter learning curve. The small cuneiform osteotomy corrects the anatomy pretty well. The only thing is we don't know preoperatively whether the head was avascular to begin with at all, because we have not seen it or not drilled it before we reduced it. Most of the surgeons talk of drilling the head first, saying that, oh, it is dead, and then they discard their case from their series. Whereas we don't know what has happened to the vascularity. We reduce the anatomy indirectly, and we have had pretty good results. So what does literature say? There is a paper in 2018 from the French area, subcapital shortening osteotomy, preliminary result, a multicentric study. And they found that modified done osteotomy for a stable slip, which was done, the AVN rates were nearing 25 to 27%. In unstable slips, it was between 21 to 24%. This is what their paper said for modified done. But when they did it from anterior approach, they had 87% slip reduction and 13.3% AVN rate, which was pretty acceptable. This is what I have been doing. So this is exactly what I've been doing, and this is what 10 institutions and 15 surgeons across France have been doing. So to summarize, in a mild unstable slip, an in situ stabilization is gold standard. You may consider PARSH if you want to still reduce it, or better still, consider osteoplasty. For a moderate to severe unstable slip, the safe surgical dislocation approach, if you are familiar with it, with intraoperative monitoring of the head blood flow with callus resection as necessary. For a moderate to severe unstable slip, alternatively, you could do an anterior arthrotomy as I showed, with a gentle open reduction and screw stabilization, or an osteoplasty of the anterior prominence if required. So again, to reiterate, a surgeon slips and falls if he misses a mild slip, manipulates an unstable slip or a chronic slip, or iatrogenically creates AVN or chondrolysis, or leaves behind a really large deformity. Thank you very much.
Thank you, Sandeep. That was a very, very lucid talk. Kapil, how are we doing on time?
Another 7 minutes remaining, so we have time for question answers.
Yeah, so let's take 2 quick comments and then or questions, and then we go on to the next talk, which will be by Dr. Kapil Gangwal himself. Premal, Jayant, anything that you all want to bring out in this?
So I think, Rujuta, I think this is a nice technique, but a lot of things happening blind. So I think safe surgical dislocation is called safe because you can dislocate safely without AVN. But that does not mean that the done procedure is safe. I think there are 2 different ways of putting the things together. It is a safe surgical dislocation operation in which you bring the femoral head out, but the done itself is it has its own risk. So I think the risk is of part of the done procedure and not of the safe surgical risk.
Premal bhai, I don't think we can explain to the patient why the AVN happened. It is because of done or whether safe surgical. When AVN happens, it happens. Yeah, what I'm saying is that the hoopla about safe surgical cut gives a wrong connotation of being safe. It's neither safe nor very easy. What I'm saying is we are familiar going in front, and the AVN rates are 10% to 12%, which is from multiple places over the world. It's not my invention. I was just doing it. I think we need to rethink the philosophy of spending 3 hours and a lot of blood loss when you can do it very easily in 30 minutes.
So Sandeep, my question will be, what will be your approach for a stable slip, which is moderate?
Yeah.
Which there is no movement between the head and neck.
Yeah, so if it is a healed slip, maybe I'll put the in situ screw and just do an osteoplasty and come out. You can see it's in the large, see, I've done more than 40, 50 now. What has happened is that only twice did I have an instance where I did the neck osteotomy and it refused to budge. You saw how the thing popped out because it is detached from the head side. Now, if it is healed to the head side, that piece doesn't come out. Then you have to make another cut towards the head side, and that makes the neck osteotomy. Okay, fortunately, in one case which I did that, I did not have AVN, I just got away. But like I said, there is no guaranteed way that you can say that the head is healed or not healed, neither by imaging. It's usually intraop. If next time, if I find that that thing is not popping out, probably I'll just trim the neck, put a screw and come out. Maybe that would be safer rather than doing a neck osteotomy. But I think, see, I've done over 40, 50 cases now. I have sent these videos to Ashok. We are publishing it. We are sending it off the data. Ashok, are you here? Have you submitted it yet?
Sandeep,
yes.
Can you get to the bump in the front with your anterior approach? Because I find that the Watson Jones is probably because you're too high on the head with an anterior approach.
No, it's very easy, James. The minute I do a capsulotomy, I put a small spike around the neck, front and back. So I'm around the neck intra-articular, and I have the whole neck in front of me. I just can't see the head, which is now lying posterior, and the posterior part is adherent to that neck part, where the vessels are lying. So I'm taking a very thin sliver from front and just an incomplete osteotomy. And when I flex the hip, in the maneuver, probably there's some green sticking. There is already a collapse of the neck because I've shortened it. So it's detensioned. And once it locks in front and you bring the hip back down, the head which was back comes in front. You don't have to do anything. You'll see the head has come in front of you. Then you just put the screw and drill it and see. It's over before you know it.
So Sandeep, one more question. What is the difference between your technique and the fish osteotomy? Which
I
was...
have no idea. Frankly, I haven't gone and dissected out what fish did. I just did this. I thought it was more logical and went by, and I improvised as I went along. Of course, when Prasad came and showed me modified, then it helped us understand anatomy better. So the safe surgical has made me refine my technique, but I'm still sticking to my technique because my avian rates are not any worse or better than what the world is doing. And I find this is very easy.
So Sandeep, just a quick question on the heads which did not bleed. How many of them really went into the AV and how many survived?
Yeah, so that's what I'm saying. There is no direct correlation. Sometimes when I drill the head for a couple of seconds, there is nothing happening, and then sort of a bone marrow or sort of a reddish serosanguinous fluid comes in, and I thought ye sala dead hone wala hai, but that didn't go to AVN. And sometimes the brisk ones, which I thought this is really good, have also gone. So overall, of all these 24 that I'm studying, I had 3 AVNs. Okay. So the rest of them have done well. So I think it's just 10%. Now, what I'm saying is the burn group, when they drill it pre-reduction, they say, oh, this is disease-related AVN. Surgeon has not created. I am safe. I don't know. Maybe it was dead to begin with here.
Okay. Sure, interesting.
Okay. So thank you, Sandeep. That was an excellent talk. Let's go on to now Dr. Kapil Gangwal, another very, very senior and dedicated pediatric orthopedic surgeon from Jaipur, and truly soft-spoken person and a thorough gentleman. Let's have Kapil talk on a very common procedure in pediatric orthopedics.
Okay, can you see my screen, everybody, and hear me? Yes?
Yes, Kapil, please go on.
Okay, so just give me one. So I'm going to talk on tibialis anterior tendon transfer for residual deformity in clubfoot. It's a really common problem, and about close to 20–30% of these club feet children are really going to end up needing this procedure. So let's look at the indications for this procedure. The primary indication is a child with a corrected clubfoot who has a dynamic supination in the swing phase of the gait. And you can see this child walking here. You can see the front and back of the foot, which looks nicely corrected. But when he walks, he turns his foot inside. And that's the typical dynamic supination that one sees with these children. Extended indication in some of the children, maybe early recurrence in a child who's non-compliant with the brace. And it's really not something that you want to push, but sometimes I've used it as a kind of a dynamic kind of force on the lateral side, which prevents early recurrence. Okay. So how to check for the tibialis anterior overactivity? This is the most challenging part of the examination. What I do is I ask the child to stand up, and I will ask him to dorsiflex the ankle. I ask them to lean against the wall and dorsiflex the ankle. And you can see that on the left side, the foot comes up nicely, but on the right side or the affected side, they really invert and supinate it. So this is an easy test to do, and these children who are 3 to 4 years of age, they will follow your instructions and be able to carry out this simple test, and it helps you to distinguish between which is the child who really has the tibialis anterior, which is causing the deformation in the gait. Well, we need to, of course, watch out for other causes for intoing, such as residual adductus. As you see in this child, he's got some foot deformity when he stands up. And if you really take an end-on view of the foot, you can see that there's an adduction deformity of the foot. And then internal tibial torsion is another problem which we need to look out for. This is the child, you can see his left foot is slightly deformed. That's how he walks. And when you ask him to do the dorsiflexion test, the foot comes up nicely, and you can see that he's really not supinating the foot. And when you look at him on the table, you can see that the foot is turned in, and there's the thigh foot angle clearly indicates that it's a case of an internal tibial torsion. So this child is not going to do well with the tibialis anterior tendon transfer, and we really need to sift out these children before we go in and do the surgery. So who's the ideal candidate? The child needs to be about 3 to 5 years of age. It's typically a conservatively treated club foot. The foot needs to be supple with abduction of about 50 degrees and dorsiflexion of more than 15 degrees. And typically by 3 years, you start seeing the ossification of the lateral cuneiform, which is the point where you're going to transfer the tendon. So you need to make sure that you do it in a child in whom you can visualize the tendon. And that's just examining the child prior to the procedure, and you want to make sure that the talar head is not prominent or standing out. The foot needs to be a corrected club foot. Typically, one needs to do a preoperative casting if the foot is tight. About 3 to 4 casts is usually what I will do. Often these children are slightly bigger and they struggle, and sometimes it hurts when you manipulate the foot vigorously. So I tend to do them under general anesthesia, and the endpoint really is to have complete obliteration of the talar head prominence. Lateral border needs to be straight, but slightly curved lateral border I would accept, and an abduction of 50 degrees and dorsiflexion of about 15 degrees. When the procedure is done under general anesthesia, child is placed supine on the operating table. You use a pneumatic tourniquet, and sometimes if the ankle dorsiflexion is slightly restricted, I'd add a percutaneous TA release to get a little additional dorsiflexion, which will help in the functioning of the tendon transfer. Well, the incision is medial, it's anteromedial, and that's how it looks. It's a small incision right over where the tendon lies, and you do a little dissection to expose the soft tissues and the tendon. Once you're done with that, you can use a slightly deeper dissection to expose the tendon, bring it into view, and then use a scissor to really lift the tendon off and dissect it down to the insertion into the cuneiform and the first metatarsal base. Well, once the tendon is fully exposed, you use a scissor to just snip off the insertion from the cuneiform and the metatarsal, and you can see that's the tendon which has been released. Once that's done, you take bundle sutures through the tendon just to have a grip on it and help in the transfer. And that's how the bundle sutures are taken. And once you've done that, you just dissect a little proximally to release the adhesions so that you can get a smooth excursion of the tendon. Well, once that's done, you're done with the medial side, and then you want to go on to the lateral. You make an incision which is centered over the lateral cuneiform. You just put a pointer on that, and you can visualize on the image that you are somewhere there. It's usually in line with the fourth ray, and it's a dorsolateral incision. That's the dissection that you do. You have to lift off the extensor digitorum brevis from the lateral side, and you have to stay lateral to the extensor tendons. And once the cuneiform is exposed, you basically just tunnel artery forceps and pull out the suture from the medial side, and that will bring the tendon onto the lateral side. And you're going under the extensor digitorum brevis and superficial to the other extensor tendons. So once the tendon has been pulled out onto the lateral side, you want to mark the point of transfer, which is the center of the third cuneiform. And you do that with a needle. And I use a hypodermic needle, and I'll poke it into the cuneiform. And then I will just confirm, looking at the image intensifier, that I'm in the right spot. So once you're sure that that's the point where you want to transfer your tendon, you use a little cautery and put a mark on it. And that burn mark is where you're really going to make the hole where the tendon is going to get transferred. So once you're sure of the point of entry, you take a drill and you make a hole into the cuneiform, and you can use sequential drilling to about 4 millimeters because the tendon's pretty thick, and you want to really make sure that it slides through the hole that you've made smoothly. So once the hole is made, you take a needle, it's a straight needle, you thread the bundle suture threads through the needle, and then make it go through the, and pass the needle through the hole that you drilled. And that's how we are doing it. We are trying to pass the tendon into the hole so that needle is going in. And you want to poke the needle out on the medial side into the arch of the foot medially. And you'll see it come out in a minute. So just dorsiflex and abduct the foot a little, and you poke the needle out onto the medial side. There it's coming out. And once the thread comes out, you pass it through a felt and then thread the ends of the Manal suture through a button. Okay, so that's the button being threaded into the threads, and then you pull the suture onto this from the sole, and you just glide the tendon through the hole that you made, and it should glide in smoothly, so that it shouldn't be like a tight fit. So once the tendon has gone into the hole that you drilled in, then you just tie the sutures over the button, maintaining the tension, and you want to abduct and dorsiflex the foot maximally so that you get the maximum tension in the tendon. Okay, so that's the tendon tied, and then you just check the tension in the suture and by looking at the tension in the tendon that you transferred, so that you can feel it with your finger and it holds the foot in a corrected position. Okay, once that's done, I will typically put some holding sutures in the tendon and in the soft tissue over the lateral cuneiform, just to make sure that the tendon doesn't slide through, or if the suture breaks, you're sure at least that the tendon is in the right place and it doesn't slide out of the hole that you made. And once that's done, it's really just closing the incision. I'll typically put absorbable sutures on the medial and lateral side, and then go ahead and cast it in full correction. So it's full dorsiflexion, full abduction, external rotation. Follow-up protocol is remove the cast at 6 weeks. After that, we typically will allow these children free walking and advise exercises for the transfer tendon. Repeat visits are at 1, 3, 6, and 12 months. And usually by about 9 months, you can see the effect of your transfer. Okay, I'm going to end with that. If there are any questions, I'll be happy to take them.
Yeah, thank you, Kapil, for a really nice, short and sweet, but absolutely to the point and practical talk. Moderator, can we start the discussion? And while I request the next speaker, young dynamic Dr. Sukalyan De from Guwahati, to be ready.
Any questions to Kapil?
Well, I have a question. After removing the plaster after 6 weeks of tibialis anterior transfer, does he need any splints or any, is there any going back to foot abduction braces, or the internal splint is good enough to maintain the correction till 5 years of age?
Oh, splint. So, yeah, some children I give anti-ankle foot orthosis for a month or so just to help them start walking. Yeah, you can allow them to walk.
Okay, thank you.
Am I audible?
No, you're breaking up, Kapil.
Yeah, but we heard, I think, most of the answers. So that is.
Yeah. Okay, so.
Let's go on to with Sukalyan's talk then.
Yeah. Sukalyan, can you share screen?
Yes. So I'll be talking about two topics. One is aspiration and sclerotherapy for aneurysmal bone cyst, and the second video discussion will be on percutaneous stenotomy in idiopathic clubfoot. So I have made a video technique video. So starting off with aneurysmal bone cyst. Aneurysmal bone cyst is a benign, non-teoplastic reactive bone lesion that is locally destructive. It occurs mostly in an immature skeleton, and it is ubiquitous in the sense that it occurs in metaphyseal region of most of the bones, long bones, bones of the hands and feet, and also in the axial skeleton. The X-ray shows typical eccentric lytic and expansor lesion, and advanced imaging shows fluid levels inside the cavity, and the histopathology shows blood-filled cavernous spaces, giant cells and spindle cells, and strands of woven bone. There might be some indication of a vascular lesion taking place somewhere inside. The exact pathophysiology of aneurysmal bone cyst is not known, but it is said that some kind of vascular malformation, arteriovenous malformation, or obstruction of the venous outflow, leading to increased pressure, coupled with the hemorrhage-induced osteoclastic activation, is behind all the phenomenon. And this is the rationale of using vascular sclerosants in the treatment of aneurysmal bone cysts. So going ahead with the case, this is the X-ray of a 3-year-old child whose X-ray was done incidentally after a trivial fall, and it reveals a big aneurysmal bone cyst. Now, the options would be endoscopic curettage and bone grafting, and open curettage and bone grafting along with implants, or excision of the lesion in toto along with bone grafts and implants. And another attractive option would be polidocanol injection, which is available in India as 3% solution. Now, sclerotherapy is a minimally invasive procedure, and which can bypass the morbidity of the conventional open procedures. In order to perform a sclerotherapy, first we need to find out the volume of the cyst. Though CT scan and ultrasound can accurately calculate the volume, even in plain radiographs, if we take the measurement of maximum diameters, that is length, breadth, and height, and get a product of it, which is actually the formula for volume of a rectangle, but it has been shown to do well with small cyst if we add the magnification factor of 10% in plain radiographs. Now, we are going to replace each cubic centimeter of the cyst space with 1 cc of 3% polidocanol. Maximum allowable volume is 10 ml, but there is a technique to get around this in cases of larger cyst, and that will be discussed later on. Depending on the location and thickness of the cortical wall, we can use either a Jamshidi needle, or we can use bone marrow aspiration needle, or a simple wide bore IV needle. It is better to have a luer lock syringe having a screw luer lock for a good fixation. This is the actual procedure in action. The insertion of the needle may require a small stab incision. The needle may be used to scrap the cyst wall while taking care not to widen the hole of the insertion. This scrapping can accomplish what many call curopsy, that is, biopsy with an intent to cure. This aspirated fluid can be sent for histopathological examination. This is how it looks like under the fluoroscopy guidance. Once the sclerogen is injected, it is injected at the rate slow enough to prevent spillover, and which is usually over a few minutes. Once the aspiration is completed, the syringe is kept in situ for about a few more minutes in order to prevent the backflow of the fluid into the open wound. It is also a good idea to use 2 needles, one for the aspiration and another for the injection, which leads to an effective displacement of the cyst fluid and is replaced by the sclerogent fluid. Sometimes dyes can also be used for better delineation of the cavity. Here is how the sclerotherapy works. The fluid inside the cavity is replaced by the sclerosant, which is either polidocanol or doxycycline. Now, especially doxycycline destroys the osteoclast, leading to a net gain in osteogenesis. The sclerosant molecule also destroys the endothelium of the connected vessels, and it leads to their shrinkage. And that's how the cyst ceases to be active. Now, each time injections are given, the same phenomenon happens. The radiographic improvement is assessed at the end of 3 months, and repeat injections are given if required. Generally, on an average, 2 to 3 injections suffice, but up to 5 or 6 injections can be given without any known adverse effects. As the cysts get smaller, it is important to be able to reach to all the loculi in order to make it disappear completely. The end result is restoration of the architecture of the bone and remodeling of the bone to a normal shape in the long run. Now let's see what happens to the case 3-year-old child. So this is the follow-up radiograph, 2 injections, 3 months apart and 15 months down the line. We can see good bone formation and along with the preservation of growth potential of the physis. Now we were talking about tiding over the problems of backflow, spillover, and limitation of maximum dose of injection, which is 10 ml. Turning the liquid into foam has been described originally by Tessari, wherein a smaller dose of drug acquires greater volume if it is turned into a foam. For this, we needed 3-way cannula. We take 1 cc of polydecanol in the lower lock syringe, and we attach it to the perpendicular arm of the 3-way cannula. On the second arm, we take 5 cc syringe and we fill it up with 4 cc of oxygen mixed with carbon dioxide, and we lock it. We don't use atmospheric air as it contains nitrogen, and there is a theoretical risk of having an air embolus going over through a possible left to right shunt if the patient has and causing an embolus. So we fill it up with 4 cc of oxygen mixed with carbon dioxide, and the opening is closed. Now we open the clock slightly, just enough to cause a turbulence, and then the repeated to and fro motion of the pistons about 8 to 20 times will create a fine froth like this. It maintains its frothy consistency for a few minutes, and it has to be injected immediately into the lesion. If we take too small and too thin bore a needle, then the froth will be reconverted into liquid. So we should keep it in mind that we use only wide bore needles in order to do that. So a sclerotherapy is not for every lesion. It should not be performed in pathological fractures, in fractures lesions which are on the verge of having a fracture or are mechanically unstable, if there is any known hypersensitivity, and if the biopsy has been performed, the sealing off of the biopsy site should be allowed, and it takes about 3 months. And it also should not be performed if the aneurysmal bolus is secondary, such as in this case, secondary to the giant cell tumor. So these are my video credits. Some of the videos have been taken from the YouTube. Thank you.
Excellent. So Kalyan, can you quickly go to your next talk?
Okay, so I'll begin. Now my second video talk is on percutaneous sternotomy in clubfoot. So Ponseti method essentially consists of 3 stages. One is serial manipulation and plaster of Paris, which corrects the cavus, adduction, and varus deformities. The second important step is the correction of equinus deformity. Before proceeding to the third stage, which is namely the maintaining the correction with the help of foot abduction braces. Now, why a percutaneous sternotomy? Because equinus is not corrected with the help of plasters. As we are talking about the strongest tendon of the human body, if we try to exert brute force, then the weakest link in the chain, namely the tarsal joint, the capsules, and the ligaments give way. They succumb, giving rise to complicated rocker bottom foot. The only way is a complete transection of the tendon, and we have indeed come a long way from the traditional multiple hemi cuts of the tendo Achilles, because we know how the tendon completely regenerates in a matter of just 3 weeks. So percutaneous tenotomy includes 3 stages. One is the injection of local anesthetic. The second is the percutaneous transection of the tendon. And third is correction of equinus to 15 degrees of dorsiflexion and followed by application of plaster. Now, when to go ahead with a tenotomy? The Pirani score is so versatile that it tells us exactly the time point to perform a percutaneous tenotomy. When the midfoot score is less than 1 and when the hindfoot score is more than 1. In other words, it means when the cavus, varus, and adductions are corrected with the help of serial plasters and the total score comes to a halt. Then the tenotomy is performed to bring the posterior hindfoot score down, which brings the total score down, and that's how the correction is achieved. Let us, for a while, visit the Pirani score. This is the lateral head of the talus, LHT scoring, and it should be completely 0 before we contemplate the percutaneous tenotomy. This is the curved lateral border, and this should also be 0. This is the medial crease sign, and its score should be either 0.5 or 0. Why not midfoot score is 0? Because the medial crease may take a longer time to disappear, and it is a completely benign thing, and it should not hold us back from performing a tenotomy. Another prerequisite is to achieve a complete reduction of the head of the talus inside the talonavicular joint, without which the tenotomy would be too premature. The third requisite is the heel must be in valgus. The fourth prerequisite is to achieve 50 degrees of abduction in an infant. In older children, it may be less. Now that we know when to perform a tenotomy, where to perform a tenotomy. So the guidelines say that it should be in any place where quote unquote a clean environment can be ensured. It can be a full-fledged operation room, or it can be a place where minor procedures are done. A very important step is always to take written informed consent. Now, how to perform a tenotomy? This is the inventory that is required in order to perform tenotomy. An important tip is to take a round scalpel holder to ease the twisting of the scalpel to 90 degrees while performing a tenotomy. As for local anesthesia, 2% plain lignocaine without adrenaline, and only a small amount would be required, not more than 0.5 ml. Because we don't want to obscure the feel of the tendon with too much of the subcutaneous wheel produced by the local anesthetic. Now, tenotomy is essentially performed in extension. That is in contradistinction with the from the application of plaster of Paris. The knee is fully extended, and there is a upward push to the foot to stretch the calf. We prep and drape the limb, and then palpate the anterior border of the tendon. We make a thumbnail indentation just anterior to it, and then place the needle about 1 centimeter proximal to the insertion of the tendo-Achilles and inject a very small amount of local anesthetic. After a waiting period of about 2 minutes, we insert the blade pointing vertically proximally at about the same side of the injection. The blade should easily go in, and once inside, we turn the blade posteriorly by 90 degrees. With a genuine gentle motion, coupled with the index finger of the opposite hand, palpating the cutting edge of the blade. This proprioceptive feedback is very important as it halts the further advancement of the blade after cutting the tendon. And because of the protective reflex, it prevents the inadvertent cutting of the posterior skin. Now, a complete tenotomy exhibits 3 signs: an audible snap, a palpable gap, and a visible gain in the dorsiflexion. All 3, as you can see. We apply pressure on the area and wait for 5 minutes until the coagulation cascade takes over. These 5 minutes are important, and they are rewarding because we don't want soakage that may seep through the plaster and spoil the mood of both the surgeon and the parents if we apply the plaster immediately. We apply an orthopedic cotton wool, taking care not to dislodge the dressing. And we apply a very snug fit plaster at first below the knee and then going up to the groin. We can fast forward it. Okay, so this is how we are applying the plaster. The final position of the foot should be 15 degrees of dorsiflexion and 70 degrees of abduction. The risks of the procedure, though minimal, should be kept in mind. If we venture too anteriorly and laterally, there is a risk of damaging the sural nerve. And if we do the tenotomy very close to the heel crease, then there is a chance of iatrogenically injuring the calcaneal apophysis, because the calcaneum is high riding secondary to the equinus deformity. So it should be at least 1 to 1.5 centimeters proximal to the insertion. After care, we can discharge the patient after a few hours of observation, which is very reassuring to the parents. Analgesics are usually not required. Paracetamol 10 to 15 mg per kg per dose, as and when required basis. No antibiotics are to be given or required. Usual plaster precautions, of which the parents are already aware of because they have already undergone many series of plasters, and we give them advice to come after 3 weeks. My special video credit goes to Cure Internationally India Trust, the organization which has been persistent in training doctors all over India in Ponsity technique. Thank you so much.
Lovely, Dr. Kalyan. Sanapa, any questions or comments before we invite Dr. Vijay Sriram, our exclusive trauma specialist from Chennai?
Exclusive. When did I become?
So, Kalyan, just one question. When
Yes.
you do your biopsy, do you wait for the report before you do the sclerosis? Or you assume that
Exactly.
case that you showed, I didn't see an MRI. At least an additional imaging to confirm that the pattern of MRI is.
That's right. That's right.
Do you do it in stages?
That's right. We can do do a histopathology or an MRI or advanced imaging.
No, can or should?
If we are in doubt, then always a histopathological examination should precede the definitive.
Yeah, I think it's important to learn because the aneurysmal bone system coexist with other pathologies.
That's right.
Malignancies, because you know, secondary aneurysmal bone cysts are also known with.
That's right.
Other pathology. So we don't want to really be on the wrong side.
Get into trouble. Right.
Yeah.
Right. So a biopsy and then followed by
normally what you do
therapy
is
after
you
3
do a
months.
wall scraping biopsy, confirm it's ABC, and then you do it. Because sometimes if it comes with something or if there's a solid component from where there is supposed telangiectatic osteosarcoma with secondary aneurysmal bone cyst.
That's right,
then we'll be in deep shit. So for the general orthopod, please don't go away with the message that you can do this just on an X-ray. At least you must have an MRI which shows you fluid levels and no other pathology.
That's right.
If you see some or biopsy, better biopsy.
That's right, sir. That's great. Point accepted. Yes.
Okay, now I invite Dr. Vijay Sriram from Chennai to give us a really good roundup of technique of tense nailing.
Thank you, Rujita. Can you see my screen, everyone?
Yeah.
Yes, go ahead.
And I'm audible, right? Yeah. So thanks for inviting me. It's been very interesting watching all these videos. As always, I learned new techniques which I didn't know before. So let me run through ten nailing. Basically, it's usually mostly used for fracture shaft of femur in children. Can also be used in other instances. I'll try and touch upon it, but I'll stick to femur mostly. So I'll just straight away go on to the treatment. I think we don't need to do anything else. Ages 4 to 6 becomes a gray area. You can do early spica casting, you can do traction spica casting, you can do submuscular plating, you can do flexible intramedullary nails. I'll come to that. But the TENS is primarily used in this age group. In the 6 to 11-year age group, in fracture shaft femur, we have, what do we have in the armamentarium? We have TENS, we have submuscular plating, we have external fixation. But what has become the gold standard now is the TENS nail. I don't think there's any doubt. All over the world, everyone uses this. And this is something even a general orthopedic surgeon should know how to do well. So what is TENS, otherwise known as ESN, elastic stable intramedullary nailing? You have, this is the armamentarium that you need. You have nails from 2 mm to 4 mm at with 0.5 millimeter increasing gradation. The tips are always curved. It's mostly blunt. You have some makers which have a sharper tip, and you got to be a little wary about the ones with a sharp tip. You need to have a slightly blunter tip. And then you have an awl, you have the curved awl, you have the straight awl. You have the chuck, the insertion, ram, etc. I never use the ram. I'll just come to that. I just use the chuck. And in the chuck, you have a short end and a long end. So basically that gives you the orient. You can put the tip of the nail, which direction it's facing accordingly to the chuck, either to the long end or the short end. So that as you're going in, you know where the tip is facing. Either the tip is facing lateral or medial, and you don't have to keep shooting to see where the tip is. And you can turn the nail accordingly. And then you have this extractor inserter. This is the breaking tool. And this is the impactor, the F tool, and this is the most important one, which is called the F tool, which is used in for your close reduction. Principles, I think all of us know this. It gives flexural stability, it gives translational stability. So it's a very stable fixation. There's no doubt about it, and it's been borne out by many studies over the years. Titanium versus stainless steel. Why not use stainless steel? Steel is stiffer than titanium. So titanium nails are more flexible than steel. There's better biomechanical stability in torsion and axial compression. There's better gap closure. We can achieve good compression and a decreased nail slippage. But there have been reports on stainless steels where you have good, better clinical outcomes than with titanium. So, but the world has moved on to titanium. Ender's nail, all those in Gujarat, some in Maharashtra, I know Premal is here. This in fact is a case of Premal's. I have no experience in this, but they have a lot of experience in Ender's nail, which is stainless steel. It's a 7-year-old close. He's done the superb nailing, and you can see that it all heals well and with an excellent clinical result. So this also can be done. And I'm not saying that titanium nailing is the only answer for fracture shaft femur. Advantages, why do we do them? Short hospital stay, early mobilization, avoid complications like shortening, angulation, avoid hassles of POP care. There are limiting factors which we have to know. Limiting factors are 11 years of age and 49 kgs in body weight. It's a little bit stretchable here and there, but this is a general rule that children over the age of 11 and those who weigh over 50 kgs, you can't nail them. Principles are very important. You need pre-bent nails of equal diameter. You cannot put unequal diameter nails as they will cause varus or valgus at the fracture site. You have to have a good pre-op assessment of the nail size. You have to put in the largest nails that can be passed into the femur. I think that's fairly straightforward. They have to occupy 80% of the canal at its narrowest diameter. So the diameter, if you measure, say, 5 mm at the narrowest, you multiply it by 0.4, and your size of the nail will be 2 mm. That's just an example. No femur that you're going to nail is going to take a 2 mm nail. So you're going to have 8 mm, 9 mm, sometimes even 10 mm, where you have to use a 4 mm nail. You need a normal size radiograph. Remember, we're living in an era of digital x-rays. All the x-rays are compressed. So either you ask for a normal size radiograph or you find out what is the compression factor and apply that to your calculation. So that's very important. You need a fluoroscopy table. That of course is obvious, or a fracture table. You have to have, you could either do retrograde or antegrade incision. All of us do retrograde. Entry points should be mediolaterally at the same level. That's also equally important. So that's how it is, at the same level, and you need to be away from the distal femoral physis, at least an inch away. Okay, so that you protect the physis. Bending the nail is important. You have to give a good convexity, maximally at the fracture site. Remember, you use a tool to bend. Use a bender, French rod bender. Do not bend with your hands, as you'll create a multiplanar bend of the nail and not a uniplanar bend. Technique, entry point, use an awl, you drill it, use an awl, nail insertion. I'll come to all that. Advance the nail till the fracture site. Do not cross the fracture site to the first nail. Then the second nail is inserted, also brought to the fracture site. Both nails are at the fracture site. And then advance one nail. The initial, what we all learned was try and advance the tougher nail first. But I think that doesn't make sense. Insert whichever nail you can to reduce the fracture. Once you got it across to a reasonable extent, insert the second nail, and then get a good spread of the nails at the fracture site. So this is what I said, you're bending contouring has to be maximally at the fracture site so that you get maximum convexity at the fracture site. So your lateral nail should go all the way to the trochanteric apophysis. The medial nail usually goes a little bit into the neck. Then you cut the nails short, as I'll show that. So you cut the nails, impact them in. I have a video. Let's see if it plays. So this was a case I did years ago in Ganga Hospital. The child had a fracture shaft femur. That was a fracture shaft, simple, straightforward. They stabilized it with an X-fix. And I went in to remove the X-fix and nail it. So that's the fracture. I used this entry point
Vijay,
where the distal shank screw was, because there's no point putting another entry point.
Vijay, we can only
And
see
I'll
your
just move
slides, your
forward.
video.
So this was the armamentarium that you should have all of this on the table. You should have a full set of nails. You have this French rod bender, and then you have the chuck here, which I said with the long handle, short handle, and then the impactors, and a full set of nailing, the ram, etc., which I never use, but it's there. Those are the nails.
Vijay, we can't seem to see your video, Vijay.
And that's the bender which I'm going to use. I'll show you that later. That's a simple French rod bender.
Vijay, stop. Vijay.
Run this through. That's the impactor that we use at the end. That's the impactor.
I don't think he can hear us. Finally.
So once you've prepped this thing, we make a very small. I use a regular fluoroscopy table. I don't use a fracture table. And I'll come to that. The first step is in templating the nail. So I keep the nail over the femur and I identify the fracture site. I know where my lateral nail is going to be. That's where it's going to end roughly. So I put a cockers there, like that. Sorry, yeah. Identify where the nail is going to, where the maximum convexity is for both the lateral nail. And then I do the same for the medial nail. I know where my nail is going to end. And I also put a cocker at that point because the nail will be slightly to bend at different places. Once I do that, I use the French rod bender to create the maximum convexity at that point. Remember, always use the French rod bender. Make sure that the nail is not bending in different planes while you're bending it. That's very important. So that's how the nail is bent. And then both nails are pre-bent. You don't do this afterwards. I like doing it well before I start the surgery so that I'm absolutely ready with it. Once I'm done with that, we go on to the exposure. We make, all of us do this. We make a small incision on the lateral side, cut the vastus a little bit, go in, and then put in the awl. So we make an awl, make it fairly large. If you're using a 3 mm nail, I at least make a 3.5 to 4 mm opening. Use the awl to enlarge it so that my nail goes in easily. And then the same thing is done on the medial side. Now with the medial side, I do a small, I take the medial nail and I always bend the tip a little bit more on the medial, for the medial nail, because I find that it bounces off the lateral cortex far easier if the tip is bent a little bit more than what it is on the lateral side. So I bend the tip of the medial nail a little bit more than what I do on the, what is there already. So that is one thing I've learned. That is easier once you bend the tip on the middle of the medial nail a little bit more, it bounces off the lateral cortex easier. Then insert the lateral nail. I tend to insert the lateral one first, just because it just makes more sense to me. If I'm on the lateral side, advance it till the fracture site and stop. And then the medial nail is inserted. You can have your assistant do it, or you can do it yourself if you're alone. Again, the medial nail is progressed up till the fracture site, and then we go about reducing the fracture. So in fresh fractures, it's very easy to reduce. It's not tough. Just give traction. You can use the F tool. You can use the bump under the thigh to get the fractures in alignment. We pass one nail, whichever is easier, it goes in, and that will stabilize the fracture. You push it into a fair bed, and then go on with the second nail. So just this, I'm particularly showing this because once you put in the first nail, it's not always the second nail is going to go in automatically. So you may have to again re-reduce, manipulate a little bit, and then get the second nail in. Yeah. So once you get the second nail in, you progress it up the canal and make sure that the lateral nail ends close to the trochanteric apophysis. You don't want to pierce the trochanteric apophysis. And what I do with the medial nail is I like going up into the neck for all cases wherever the fracture is, just because there are proximal fractures where I nail, there are cysts where I use nails, and I need the nail up the neck. So it is just a practice for me. You do a frog lateral, look at the neck, make sure that you're well inside the neck and go up as far as possible. And this is where the fracture was. And you can see that the spread is maximal at the fracture site in the AP view. And the same, you can see that I'm pointing to that. You can see the spread of the nails at the fracture site, the maximum convexity is there. And even in the lateral, there is a good spread at the fracture site. So this is what is essential. You don't want what is called a corkscrewing of the two nails where it twists on itself and you have no spread at the fracture site. And that is where the nails end up proximally. And that's just coming to the cutting. So once you've inserted the nails, and then I tap them in the end. So that's me just tapping the nail in. And I like leaving the nails short. I leave them against the bone like that. I leave them short because I don't remove these implants. Now the world is divided between those who remove the TENS nails and those who don't. There's enough literature on leaving them in. There's enough literature on pulling them out either. I don't remove them personally. So we'll go to some examples. This is a 4-year-old. You can see that the shortening was quite a bit, more than 2 centimeters. The child was chubby. I was not sure I could do get away with just a spica. And so I decided to nail, and you can see again, same principles. You have to have good spread. The nails go in long enough, 6 weeks post-op, 18 months post-op, there's no real problem. This is another 6-year-old. Again, this is an indicated case, absolutely indicated. You can see the spread of the nails at the fracture site 2 months later. This is a 4-year-old child with a proximal shaft. Now, this is where you got to learn how to get the nail in long enough. So this is again a close reduction. And you can see that the lateral nail has gone into the trochanter. The medial nail has gone up the neck with good spread of the nail at the fracture site. So your bending has to be according. You just don't bend the nail and the middle of the nail. You template it where the fracture is and bend it there. 3 months post-op, it all heals well. 8-year-old male, again, similar. Now, and you can see they all go on to heal well with a good result. What are the complications? This is not a perfect system. You have to know where the problems lie. You can have loss of reduction and what are called linked unstable fractures. This is courtesy Dr. K. Wilkins, who taught us all, basically taught us pediatric trauma over the years. So this is the post-op case, and this is what happens 1 week later. There's a huge fragment there, like a butterfly fragment, and that will collapse. What he taught us was to put in simple X-fix for a few weeks and then remove it. Just 1 pin proximally, 1 pin distally. That will go on to heal well. Now, this is a 7-year-old boy. This was the case. I think I had a wrong X-ray. It measured 5 mm. Anyway, I tried putting in bigger nails. I ended up pushing this fragment away proximally. It became a length unstable. So what I did is I just added 2 mm KOIs with a just distractor on the side, kept it for 3 weeks, and that went on to heal well. That's the final result. And I do it simply on a fluoroscopy table because I can check rotations of the hip, rotations of the femur and the alignment much easier than I would on a fracture table. There is a 3-nail concept, but that hasn't really taken good hold. This was a child which was done by a colleague of mine. You can see what happens. He ultimately managed only to put on 1 nail. He put a spica. This is not ideal at all, but because the child is a child, this is 6 weeks post-op, and that goes on to sort of remodel. Okay. So, but this is not ideal. When you do it, you got to learn how to do it properly. You can have missed lateral injuries. This is a child I nailed. This is 8 years old child. I had a hematoma. I aspirated the knee. We couldn't find any real injury on the X-rays, but there was a hematoma with flat globules, I should have warned the parents. Anyway, I went ahead and nailed the child and then came back with a bar and a flexion deformity of the knee. There was a posterior bar and that had to be reconstructed later on. So you can have malrotation. So that's why I do it on a regular table where I check it always after nailing. Irritation from the nail ends, you know, to remove it. And sometimes you can get a procurvatum deformity. Tibia also can be nailed similarly. My indications for nailing tibia are rare and few. I don't nail them usually, I treat them conservatively, but it's the same principles, same spread of the nails, exactly the same. And in forearm fractures, again, my indications for nailing forearms are not very frequent except when there are floating elbows. The same thing. What is important in the forearm fractures is you got to maintain the intra-osseous space. So your contouring has to be to that. Humerus too can be nailed similarly. And that's the follow-up where everything heals well. In conclusion, this is not flexible intramedullary is effective, relatively economical method of fixing femoral fractures in the 4 to 6 years and definitely in the 6 to 11 year age group. And in the older children, you don't do this. You do rigid lateral entry dock nails. External fixators and submuscular plating are still useful in the use. Thank you very much.
Thank you, Vijay. That was a very detailed talk indeed. I think there were some bandwidth issues. Can everyone hear me?
Yes. I can't hear you.
Vijay, except you, everyone else can. Anyway, thank you. That was a lovely talk. So we'll go on to Atul now for the interest of time. And since we have a lot of questions and this thing's still coming in on YouTube and a lot of topics yet to cover, what we'll do is we'll make a part 2 of this entire series to cover the topics which haven't been done today. Yeah. So our last speaker for the day today will be Dr. Atul Bhaskar. I will also probably come in addition to only. So
Okay,
Sandeep will
Rojita, I
moderate
didn't
this
hear
talk.
anything. Were there any questions? I didn't hear anything you said.
Can someone else tell him that I think he's the only one who can't hear?
No, now I can.
Okay.
Vijay, everyone else could hear except you.
Okay.
Over to you, Atul, a dynamic and omnipresent pediatric orthopod from Bombay.
Can you see the screen?
Yeah.
Okay, so I'm just going to speak on torticollis, which is the topic which I've been given to. So, as most of us know that idiopathic torticollis, we don't tend to operate in children less than 4 years. So, my indications are if there's persisting neck tilt or contracture beyond age 4, if there's progressive deformity despite all our conservative methods using collars and physiotherapy, when the rotation restriction beyond 30 degrees, and there is a gaze deviation, which is the tilt of the head beyond 30 degrees. So these are severe torticollis. By and large, most children will present between age 1 to 3. It's very difficult to do surgery at that age because the compliance with physiotherapy is very poor. Also, they will not use the post of brace. So typically, we assess the torticollis in this fashion. This is a 7.4-year-old boy who had, you can see the left side torticollis with tautness of both the sternal as well as the clavicular head of the sternocleidomastoid. We also look at this angle, which is the division of the horizontal, the what is called the Frankfurt plane, line joining the outer corner of the eyelids, and measure with the horizontal. Other thing we do is we measure the chin deviation from the plumb line. So the plumb line here is the mid-sternal line, and how much is the deviation of the chin from the midline. So usually if it's more than 3 centimeters, this deviation is more than 30. Usually these are what are called severe torticollis. And you can see also there is additional facial asymmetry. So these are surrogate markers for facial asymmetry. You can see there's a malar mid-facial atrophy. And so this is what we assess the child before surgery. Also, we need some imaging. So we always do cervical spine X-rays to rule out any anomalies. After evaluation to make sure there is no pre-existing ocular disturbance. MRI CT is not required unless you are not sure about the X-ray. And there are certain softwares now available where you can do a photograph of the child's face and then assess facial asymmetry. but these are not very commonly used in practice. So this is a 12-year-old girl, and you can see she's got this severe right side torticollis. Again, same parameters have been used to measure that, the gaze deviation and the horizontal translation. When we go for surgery, it is worth spending about half an hour in trying to position the patient well, because the key to surgery is the position. And so typically we would have under general anesthesia with an endotracheal tube on the opposite side. You place the head in such a way you can break the table here at the level of the head and neck junction, so that you can do intra maneuvers. Sometimes I would use this bands, micropore tapes to stabilize the arm as well as the head, but you don't need them all the time. This is only to make the muscle taut. But remember, these things have to be removed intraoperatively. And you can drape the head free once you've done that, and you make a small transverse skin crease just above the clavicle. Don't go over the bone, because you can get bad scar formation as well. And in addition to the band, you can also see sometimes there are taut muscle fibers and platysma above the external jugular vein. So this is the area which you can undermine and cut the fibrous tissue. So typically we would expose both the heads, the sternal as well as the clavicular head, and I would resect it rather than doing this technique where they recommend you cut the clavicular head but do Z-plasty of the sternal head. Because these are fibrous bands, you will get a recurrence. So normally I would resect. I'm not worried about the contour, because generally you will find they will reform in a slightly extended position. The important thing is that intraoperatively you should try and maneuver the chin back to the midline. You should get a full neck flexion and rotation intraoperatively, so before you close the wound. So you must, at the end of your surgery, after you do the unipolar release, tell your anesthetist to hold the tube, and you can then move support the head yourself, and then maneuver the head in all directions. If you have to do a bipolar release, take an incision above the mastoid, expose the bone subperiostally, because you want to avoid the facial nerve in the front, the auricular nerve inferiorly, and the accessory nerve distally. So you have to make sure that you don't damage the nerves. Typically, if you don't get the intraop correction with the unipolar release, then I would go ahead and do a bipolar release in the same child. So usually there are 7+ age children where you need a bipolar release, and if you have a severe torticollis. So this is our distal exposure. So you drape the patient well. This is the tendinous part which is contracted. This is the lower end of the tendon which is cut. And then once you cut this tendon, you go to the underlying fascia as well. Cut the fascia. You can see some taut bands on either side. And you get good correction intraoperatively. Immediately after the surgery, we apply this kind of temporary collar, which is just made of cardboard and a normal modified polypropylene collar, which has got a slightly elevation on the side of the surgery. Important thing is to start physiotherapy after 1 week, because for 1 week they're usually painful. Once the wound heals in about 5 to 7 days, start active movements. This is our protocol. A lot of head suspension, position, lateral translation exercises, and this is part of the protocol for 6 weeks. And then later on, after 6 weeks, we can reduce the collar, but continue the therapy for 3 months. So this is a couple of examples here. This is a child just immediately 2 weeks post-surgery after the wound has healed, and you can see the correction on the right side, and this child undergoes extensive physiotherapy. Similarly, this girl, you can see the right side torticollis, and here she is. You should tell the parents that the facial symmetry will take almost a year or 2 years to recover. It doesn't recover completely, as you can see, and the scars heal quite beautifully. You take subcuticular stitches. So I think this is my first talk. You can have complications as well, so be careful about scars. So don't use subcuticular stitches. You can get residual tightness. So make sure during intra maneuvers you release all the tight bands. Nerve injury can occur if you go too deep. If you miss the plane, I've seen injury to the brachial plexus as well if you're over enthusiastic in trying to release a deep fascia. Relapses are common if you have done the undercorrection. And facial asymmetry, again, like I said, you must counsel the parents. That will take a while to recover. So that is in short about torticollis. Rujuta, you want me to go ahead or for the hip part?
Yeah, I think so. Let's finish your talk at least in toto.
Okay. Yeah, so my next talk is on acute septic arthritis in a child. Essentially, these are surgical emergencies because of the rapid onset of this infection. In some children, you will have systemic illnesses which may be predisposing to the infection. Typically, the child will present with the refusal to move the joint, or what is called pseudoparalysis, and any attempts at passive movement is extremely painful. If the joints are superficial, you may find effusion, but if it's in the hip joint, you can notice the typical flexion abduction posture in the child. The reason this becomes important is because infection in neonates and infants can rapidly spread from the joint into the bone, or from the bone into the joint. So the pus or the swelling can easily traverse because of the nature of the epiphysis, which is intracapsular. So hence the signs and symptoms are sometimes minimal, but local examination is the key for these things. So one can, in a smaller child, one can use the stepping reflex, and you can see sometimes these children will not bear weight on the affected leg. You can do a suspension test, like in this child, you can see the child is not extending the leg at all. So this comfort position of flexion is because of the pain. Any attempts to passive extension will cause extensive crying or pain in the child. So this usually is a hallmark of infection. You may have some differential diagnoses like transient synovitis in the older child, cellulitis, birth fractures, and very rarely metabolic bone disease leading to fracture with pain in a child. No treatment is complete without basic investigation. So one must have all these done, and also do a basic imaging X-ray to make sure there is no lytic areas in the bone, you don't miss anything, and also advanced imaging like ultrasound scan and MRI if it's possible, and it doesn't delay your treatment. So ultrasound scan can reveal if the X-rays are normal, can show periosteal elevation, swelling in the capsular area, and you can see in this child where there's massive swelling in the joint. So at least you have objective evidence that there is collection before you intervene. Similarly, you can get joint subluxation and dislocations with septic arthritis. So ultrasound is good to document the problem before surgery. There are certain criteria which will guide us about treatment. So generally, if the temperature is more than 100, not responding to your medication, high counts, raised ESR, and of course, clinical signs are extremely important. If you have these criteria present, more or less, it's more than 4 of them are present, invariably it is septic arthritis. If the child, if you got 2 or 3 criteria present, you can still start with IV antibiotics. If the child responds within 48 hours, then you can continue with conservative treatment. If there is no clinical improvement within 48 hours, then one has to intervene surgically. And there are various options. You can either do a lavage or aspiration lavage. This is easy procedure, can be done in the outpatient, also the ward, especially if the child is very sick. But there are always disadvantages. You may not have imaging possible all the time, and again, it needs a high level of expertise to do these, especially in the hip joint. So this is an example of a 7-year-old child who presented with the inability to move the leg since 5 days. This was a differential given by the pediatricians. There was fever for 2 days. In fact, they had taken a sample for poliomyelitis, so they had the stool sample taken. His MRI revealed collection inside the joint, and you can see that there is a fluid collection in the joint. This is the collection, and he was toxic. So we did an aspiration which can be done from the medial side. You can use the adductor portal, the lateral portal, or the anterolateral portal. If you want to do a lavage, you need 2 portals so that you can thoroughly wash this joint. So this family was counseled that we will do a lavage first and see. And this is how the lavage was done. So you use fresh saline, you aspirate from, and then you can see the pus coming from the other side. So this thorough lavage. The initial sample was sent for culture and drug sensitivity. And following this, child made a dramatic recovery. Here he is post-op. So I must thank my co-fellow Dr. Chintan, who shared these slides with me. So this child responded very well to aspiration. But this is not always the case. If you find there are problems following aspiration, they get a recurrence of swelling, please do not rely on aspiration. You can still may have to do an arthrotomy. So this is another example of aspiration, courtesy Dr. Rujuta, who shared these slides with me. So this is the adductor longus tendon. You put a 18 gauge needle inside, make sure you're in the joint. And here you can see pus being aspirated, and then you can lavage the joint. Arthrotomy, of course, is the mainstay in children where there is a severe infection and you're not comfortable with aspiration. The advantages are that you get complete look at the joint, the cartilage as well. You can do a thorough lavage. You can do metaphyseal drilling, and also you can put a drain and make sure that the infection is under control. Of course, in each expertise, sometimes you may need blood as well in a child who's compromised in terms of medical issues, and it may increase the hospital stay. But certainly, nobody will blame you for an arthrotomy in a septic child if you're trying to drain the hip or any other joint, even if you get a negative arthrotomy, because the main thing is to save the joint. So I would use the modified Smith-Peterson approach, center your incision on the anterior iliac spine, reflect the muscles, the TFL, the sartorius. You will see a bulging capsule. Before you incise the capsule, you aspirate, send the pus for culture or an antibiotic sensitivity, open the capsule through a T incision and do a thorough lavage, move the joint through its range so that you can clear all the pockets of pus. I would not use any drain unless there is a massive abscess. Then only I would put a drain. But if it's just a septic arthritis, you don't need a drain. You can make some drill holes in the metaphyses if there is osteomyelitis in the proximal femur, and you must clear all the subparacial abscesses without leaving any pockets. Post-op, you can use a simple abduction brace, abduction cast, or a spica to prevent post-operative spasm. So a couple of examples here. This is a child. You can see X-rays are almost normal. This collection you can see along the muscle plane inside the joint, and this is how you approach. You can see this thick debris and pus in the joint, and this is the other picture where you can see pus pouring out. So this is not uncommon in our practice, because sometimes children present late after 3 or 4 days to you, and then arthrotomy is the only procedure to salvage this joint. And like I mentioned earlier, infection can spread rapidly through the transfascial route. So this child had a lytic lesion in the proximal femur where we did the arthrotomy, and children also respond dramatically. And this is this post-op after 9 months post-op. You can see it's completely healed. So the children will respond dramatically after you clear the infection, and at the same time they need systemic antibiotics for about 4 to 5 weeks so that they don't get a recurrence. You can have sequelae if you don't intervene on time. You can get this kind of lesion in the neck, which can destroy the bone. So this child had a complete loss of neck despite an arthrotomy, because he presented almost after 10 days, and he also had a thigh abscess. So thank you very much, Rujuta. That is in conclusion that it's a surgical emergency, and don't try and delay treatment of any septic joint in a child. Thank you very much.
So lovely talks by everyone. I think we'll just have 2 final comments. Kapil has been too quiet, so as our co-convener, maybe I'll ask him to summarize some of the salient points.
Rujuta, can I ask up to a quick question?
Oh, sure. James, of course. Our pleasure, totally.
Thanks. I'm sure in India, there are quite a number of patients who are delayed in diagnosis in torticollis, like you may get an 8 years old or 9 years old or even 12 years old patient. And the ophthalmologist will tell me that our eye-brain coordination, meaning once you look at the world that way, after 9, they cannot readjust back. So do you have patients who after 9 years old, you found that their tendency, they want to drift back to the previous way of looking at things, looking at the world?
The gaze angle. Atul, I think we'll take the question back to you.
Sorry, I didn't get the question, James. Can you just summarize it?
Oh, so sorry. Okay. Now I'll do a quick one. Ophthalmologists will say that after 9 years old, the brain-eye coordination already halfway has formed. Therefore, those patients you do at, let's say, 12 or 13 years old, you have problems of them tend to tilt back because they have been looking at the world that way, for so long.
Correct. Yeah. Okay, James. Okay, I got that. Okay. So James, what we do is we get children coming even at age 12, and I've done older children as well. I take a point that they have adapted to that position, but they usually get back to, if there's no ocular problem before, there are no issues before we get them evaluated, they usually adapt. And one of the reasons, we do the surgeries because I get patient referred from the school. The child parents say that the child cannot look at the board properly because he's tilted, and the parents are concerned. The sports doctor in the sports person in the school is concerned that child cannot participate in gymnastics. So I've not had any issues in older children. We've done even at age 20 torticollis correction, and usually it's not an issue unless they have underlying problems. So I don't know. I think Sandeep has also got a paper on this, and I think he can also guide us. But I've not had any hostile issues.
James, I had published in 2013 in JBJS adult patients from 18 to 42. The oldest was 42 years old. And all of them are satisfied with their cosmetic appearance, neck motion improvement, and none of them had any neurological or visual problems. As Atul said, it's a perceived notion. They had been refused surgery at many places, saying you might end up with neurological problems or visual problems. But it really doesn't happen. It's more of a fear, unless you have pre-existing ocular problem as a cause of torticollis.
In fact, they come during adolescent, and because they refuse a driving
manageable
license.
age.
They refuse a driving license because they can't bend their neck. They don't get a motorcycle license. So I've got children coming at 18, 19 for correction.
Yeah, absolutely.
So I think we've really come to the end of a really long day, and there were a great many topics still remaining. But I think it will be nice if we can do a part 2. Since this was a mini workshop, we'll stick to the at least one topic covered so far. And all the speakers have done an absolutely excellent job. And I thank all of you all from the bottom of my heart. I thank my co-conveners, Dr. Kapil, Dr. Sandeep, for a very engaged discussion and absolutely practical points on everything. Dr. Vijay, Dr. Jayant, Premal, Varun and Taral, Sukalyan, Maulin, Premal, everybody, thank you so much. Ashok, of course, for being the total stalwart and backbone of support for the technical showcasing of this workshop. And James, what a lovely, pleasant surprise to have you with us from Singapore. And I thank IOA and the committee for giving us this opportunity. Thank you very much. And looking forward to seeing all of you in 2021 in Mumbai. And thanks, Atul.
Certainly.
Thank you. Thank you, Rujita.
Hi, Rujita.
Thank you to the audience as well. Thanks.